بسم الله الرحمن الرحيم إنا أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر.
Today we are diving deeply into the diabetes complication in the elderly, the home care in the elderly population, and the social implications in Pakistan population. I'm extending my heartfelt appreciation and gratitude towards my speakers today, namely Dr. Aisha Sakim, Dr. Abdullah Gujar, and Professor Dr. Muhammad Imran Hassan Khan. Along with that, we are also having a rapporteur today, who is Associate Professor Dr. Nasir Bhatt. Thank you, sir. Welcome. So, to kick off our scientific session today, I'm starting with the talk of Dr. Aisha Sakim. And before I welcome her to the podium, I would like to have a little introduction about Dr. Aisha Sakim. She is a consultant physician at Guy's and St. Thomas NHS Foundation Trust in London. She serves as a national committee member for the Association of British Clinical Diabetologists and is the quality improvement lead for the Acute and General Medicine Directorate. She has led several trust-wide quality improvement initiatives and has disseminated her work through presentations and publications in British peer-reviewed journals. Her clinical interests include the care of young adults with diabetes, management of diabetes-related complications, inpatient diabetes care, and perioperative diabetes management. Please give a huge round of applause to Dr. Aisha Sakim.
Thank you so much for your kind introduction. It was very long. I should have given you a shorter speech. So nice to be here. It's so nice to see all of you. And thank you all of you for joining us today for this session. I hope you find it beneficial and useful. I will hopefully leave some questions, time for you to ask some questions at the end. But during the talk, I'll try and give you an overview of how to manage diabetes as you try and manage older people or people with other comorbidities as well. So, obviously, I want to give an overview of newer drugs in diabetes, even though they're not that new, but some of you might find them in your practice. They are the newer agents we use. We talk about frailty and how to optimize diabetes. And I wanted to touch a little bit about diabetes technology and how its use can benefit management in older people. So SGLT2 inhibitors, these are the class of drugs which make you pee out urine. This is how we explain it to patients. The standards that we use in the UK are canagliflozin, dapagliflozin, Enfa, and Urdu. Indications, obviously, you can use it for diabetes, for heart failure, or for chronic kidney disease. So there are 3 indications. You might often see people when you're clocking them in or taking the medical history that they are on an SGLT2 inhibitor, and that might not just be for diabetes. And obviously, when you try and start people on SGLT2 inhibitors, you explain them 6-day rules that whenever you are unwell with any comorbidity or any illness, diarrhea, vomiting, or anything you do like, you hold these medications and you restart when you start to feel better. And obviously, you need to be very aware of euglycemic DKA. So if you see patients on these drugs and you're trying to admit them into a ward, make sure you check their blood sugars and their ketones because they could still be in diabetes-related ketoacidosis despite having normal blood sugars. Another newer class of drugs are your GLP-1 analogs. The oldest one is exenatide. We don't use it anymore. It gave a lot of adverse skin reactions when you would inject them. Once daily liraglutide, once weekly dulaglutide, lexasenatide is more in use, in UK at least, and semaglutide. I'm not talking about the dual GLP-1 and GIP agonist, Mounjaro, which is very commonly used initially in the US and more recently in the UK as well. And then we have triple agonists coming in early next year, which are going to be the Mercedes-Benz of weight loss and diabetes drugs. We'll talk about them hopefully in some future sessions. And obviously the biggest benefit from these drugs is weight loss. They work on multiple receptors in the gut and in the brain. I'm not going to go into details because we're going to manage and focusing on diabetes in elderly. I'm giving you an overview of these drugs because their use in elderly population has to be very selected and you have to be very mindful of other comorbidities when you're making your decision. Obviously, you use it with caution if there's history of gallstones or pancreatitis. It's not an absolute contraindication. However, you must seek consultant advice if you see a patient with history of pancreatitis if you want to initiate these drugs. And they're quite expensive. In England, one pen costs you around £280. And obviously, in elderly people, you have to be very mindful because when you lose weight, you just don't lose fat, you can lose muscle mass as well, and people can become very sarcopenic and very weak and unable to get up from chair or bed, and that has to be very much accounted for. And obviously, initially when these drugs came out, we were told we need to review the indication of these drugs in 6 months. You have to achieve an HbA1c drop of 1% or 10 millimole, or a weight loss of at least 3% to make sure to advocate the use of these drugs going forward for the management of diabetes. For weight loss, there are so many barriers to starting these drugs, so a lot of people are buying these privately. NHS is a public funded system, so the government funds for it from people's taxes. So the patient at the point of use is of no cost issue, because I really want to know where patients are from. We see patients from Eritrea, Kenya, India, Bangladesh, Pakistan, Uganda, you name the country and you see people. So it's very multi-ethnic, and all populations have different phenotypes of diabetes, different complications. You see people 24-year-olds living with type 2 diabetes for 10 years. So, it's very interesting. So very important to understand the disease and the person sitting in front of you and how they live with it and how they manage it. And then obviously, I have just split it into, I've used my colleague's paper. It was brilliant. So it's referenced at the bottom. You're healthy. You have very few coexisting chronic illnesses, and your cognitive and functional status is intact. And then you have a complex or intermediate state where you have multiple existing chronic illnesses. You might have had a heart attack, but you're not in heart failure. You might have CKD, but you're not requiring dialysis. You might have OSA from obesity, and you're requiring CPAP. So it's all about trying to understand the full patient in front of you and how their disease is affecting them. And then you might have mild to moderate cognitive impairment, so onset of dementia might be, but you're not fully debilitated just yet. And then you have very complex or advanced, or you're in poor health, where you have long-term conditions, the complications have set in its end-stage chronic illness. You have moderate to severe cognitive impairment, where people sometimes don't even have control over bowel and bladder. They can be fully dependent on their carers, and they can't perform more than 2 activities of daily living independently. So the reason I'm explaining you all of this is, this will help you understand how tightly you want to optimize a person's diabetes. You don't want a 90-year-old bedridden palliative patient to have a blood sugar of 5 or 6 on waking up. You want them to have slightly relaxed control. There's a joke in our center where I do community clinics that the target HbA1c should be just below the patient's age. So if you see a 90-year-old, the target HbA1c should be just below their age. But I wouldn't tell this as to students, okay? It's just for just to give you relevance. Now I've sold everyone the top secret. Excellent. So if you're healthy, you're fit, you have no comorbidity, there is some benefit of getting good cardiovascular risk reduction. So you want to target HbA1c of 58. If it's 58 to 7.5%. Do you use percentage here, or you use the millimoles? Percentages? I'm so proud of myself. I've written the percentages at the bottom. But when I started to train in diabetes and endocrine, it changed literally from DCCT to IFFC. So I use the millimoles per moles, but you're very welcome to look at the percentage values. In complex or intermediate health, it's 64 millimoles, so 8%. And if you're very complex and advanced, it should be relaxed around 70. And when you see older people, you want to start to de-escalate treatments, because a lot of elderly are on so many medications. They go to see a renal consultant, then they put on bicarb or 4 blood pressure tablets and 2 diuretics. They go to see the heart failure consultant, then they add it on bisoprolol and spironolactone and you name it, and they have all the 4 drugs. And then they go to the diabetologist and they want to add in dapagliflozin and they want to be more. So you need to have a very good overview of who is sitting in front of you, what is their blood pressure in the clinic, what is their HbA1c, what is their renal function like, just so that you can build a mind map as to how you're going to now optimize their diabetes, because diabetes is the most prevalent comorbidity in patients. Every 1 in 4 people in the UK has diabetes. Pakistan is the 3rd largest population living with diabetes, so this is the most common comorbidity, and you need to get to grips with how to manage people in comprehensively. And then obviously if you see these people with very low HbA1cs, that is when you're going to try and de-escalate treatments and try to stop something. Now I'm going to take you through this. At the x-axis you can see the frailty is increasing. You have a fit person, and then you have elderly and some very dependent people. And frailty is not unidirectional. You can recover after a stroke. You can start to feel better after going through a major heart attack. So it's bidirectional. Obviously, there's a stepwise decline as age advances. I'll just pause for 2 minutes to welcome everyone. Thank you for joining. No pressures on me now. I'm very relaxed. Not. Okay, so we're talking about managing diabetes in elderly. So obviously you're talking about your fit older adults who are fit, like people sitting here, some of them. So you're fit, there's benefit of good glycemic control because there's still evidence that you can manage, you can achieve cardiovascular risk reduction is going to be of benefit. You can reduce the incidence of strokes, you can delay the onset of CKD, and you can delay onset of end-stage renal failure requiring dialysis. And the HbA1c target should be as tight to normal as possible. Here I've written 58. Usually in very young people we want it to be around 48, and for middle age group we target around 55. So it's still a bit relaxed for age. However, you can see we are still trying to optimize glycemic control to as near to normal as possible. You want to avoid hypoglycemia, and otherwise you will just treat them as younger adults. Okay, is that clear? Is that fair? Good. So then you move on to moderate frailty. Here you want to relax the glycemic control a little bit to slow the onset of dementia and reduce hospitalizations, because now our focus is shifting from reducing risk of heart attacks and strokes and major events and peripheral vascular disease and reducing the onset of foot ulcers. Now we're looking at preventing hospitalizations and managing people out in the community. And the target HbA1c is a bit relaxed as well, around 8%. You want to similarly still want to avoid hypoglycemia, and you want to maybe avoid using agents that will exacerbate weight loss and make sarcopenia worse. And then you have the other end where people are severely frail, they're bedbound, they're palliated, and that is where you really relax blood sugar targets. We give a blood sugar target of 8 to 15. These are UK numbers, you can multiply them by 18 to convert to your milligrams per deciliter. And then you want to avoid hypoglycemia at the same time and want to avoid the agents that will cause weight loss. Okay? Now I've made, these are 3 sets of slides, I've been very quick through them. You need to reevaluate elderly people every 3 months just to see how and where you're going to de-escalate. If the HbA1c is above target, the first line still remains metformin. Obviously you need to look at the renal function, and the eGFR is below 45 mils per minute. You should halve the dose of metformin to 500 milligrams twice a day, and if it's below 30 you should stop metformin completely. But now we are very lucky in diabetes, we have so many other agents. If they do have heart failure, you need to commence SGLT2 inhibitors. We spoke about these drugs earlier. If there's history of MI, there's role of using GLP-1 agonists, and if there's no previous atherosclerotic cardiovascular disease, you can use any of the drugs. I personally don't like sulfonylureas, and I'm very pleased the author of this paper didn't mention sulfonylureas either, because in elderly there's a high risk of hypos. They hypo all the time, they keep on eating, they put on weight, that makes the diabetes worse. So sulfonylurea use is very restricted to a very small group of people in my practice and in our center. It's mainly for diabetes related to steroids or steroid-related hyperglycemia, and sometimes when people don't want insulin and you want to bring their blood sugars down quickly, because these are very potent drugs. And if the HbA1c is less than 53, that is when you will try and de-escalate. If they are on mixed insulins, you're going to try and put them on a basal insulin, because elderly people don't eat as much as someone in their 40s or 50s or in their middle ages. So that is when you need to comprehend and change the medications around. And you can still use basal insulins with some other oral agents. Obviously discontinue pioglitazones, and you can initiate SGLT2 inhibitors instead to manage heart failure. Then you're talking about your moderately frail people where the HbA1c is more than 64. Again, you will look at the comorbidities. All of this is in the ADA guidance, in NICE, and also in EASD guidance. So EASD is your European Association of Study of Diabetes, ADA is your American Diabetes Association, and NICE is your NHS related, National Institute of Clinical Excellence. And then you have your very severely frail people, and that is where you want to keep them as comfortable as possible. Obviously, I wouldn't recommend stopping all treatments, because if your blood sugars are persistently high, what will happen? How will you feel? You will be very osmotic, you will be very thirsty and very polyuric, and that's what you don't want these people to be. So you reduce the insulin by 20% decrement, so you gradually reduce your insulin depending on the type of diabetes they have, and that is where you can consider use of continuous glucose monitoring. I'll talk about a little bit towards the end. Okay, so and then you approach the end of life where people are imminently dying within the next week or some months. Obviously, if they have type 1 diabetes, you will never stop their insulin. They can die from decay. So you can expedite their death by stopping their insulin. So always make sure you determine the type of diabetes the person has. If they have any other forms of diabetes, you can then start de-prescribing. And your target blood glucose is 160 to 270 milligrams per deciliter. And obviously, the main thing you want to do here is avoid decays, avoid HHS, and avoid severe hypos. I've seen people come into the hospital with a severe hypo. A severe hypo is defined as a blood sugar which was so low that you were unable to self-manage and you required third-party assistance. So it's not related to the number, it's related to the fact that someone else needed to save your life. And that is classed as severe hypo, and that's a never event. That should never happen in someone with diabetes. If that has happened, de-escalate treatment, and that happened in front of me. People stopped everything, and then 2 weeks later, the patient came back in with HHS, which is hyperosmolar hyperglycemic state. So be very sensible, very measured in your approach to people with diabetes, especially as they're growing old. Keep an open mind and have an overview of their medications. And obviously, just a little touch, we often use HbA1c in our clinical practice, but HbA1c is not always reliable. So again, when you try to assess, make sure there's no history of recent transfusions. Are they on hemodialysis? Do they have sickle cell disease? Do they have any condition that is affecting their red cell turnover? Because all of that affects your HbA1cs. Sometimes in clinical practice we use fructosamine, but you must know fructosamine is only a marker of blood sugar average over 2 weeks as compared to HbA1c, which is over 3 months. And then CGM is your continuous glucose monitors. They are very commonly available in the NHS now. Everyone living with type 1 diabetes is eligible for CGM, and very selected type 2 diabetes cases as well. The CGM devices we have in NHS are your Libre by Abbott, Dexcom by Clarity, and Guardian by Medtronic. Obviously, as I said to you, everyone with type 1 diabetes is eligible to use these, and selected type 2s, especially reserved for those who are on multiple daily injections of insulin. We also use pump for patients with type 1, and as you will see in NHS, a lot of older people living with type 1 diabetes are now growing old. They're getting old as to their 80s and 90s, and how you manage them. And pump is a very good use. Now they come paired with CGM as a hybrid closed loop, where the pancreas, basically they're like artificial pancreatic system, where the CGM talks to the pump and delivers the insulin automatically, and all the user requires to do is to give their bolus insulin prior to eating their food. And it suspends insulin delivery as soon as it detects a hypoglycemic episode. But again, as I said to you, the use is only limited for people with type 1 diabetes. Cambridge and our center are doing a study on people with type 2 diabetes and insulin pumps. The results will not be available for the next 4 or 5 years because we are still recruiting people and to see how beneficial it is for people with type 2 diabetes. Again, this is the hospital I work in. I love my job. And if you ever come and see Big Ben or the Houses of Parliament in London, I work right in front of them. Any questions at all? Do we have time for questions?
If you have a talk in another...
yes, I do need to run.
We'll just take one question if
Yeah.
there is any... anyone has any question. Because
Yes.
we'll have a dedicated
But
section.
we also impose a substitute that HbA1c can't be used to monitor the progress in patients with iron deficiency or sickle cell. So, how can we monitor the progress in these patients?
So I would still do an HbA1c because that gives you an idea. You can still assess as to how bad it is, how suboptimal the control is. And then I often look at the blood sugar readings. And the best measure in type 2 diabetes is your fasting blood sugar level, because after food it can be any number. And you want to ask the patient to take your blood sugar at the time when you can make a difference. For example, if they're on a basal insulin, you want to know what the blood sugar is before they are eating, before they're going to bed, to make sure they are not hypoglycemic. If they're on mixed insulins, you want to know the blood sugar 2 hours post-meal just to titrate the blood sugar. So blood sugar ranges. And then obviously we use CGM, which is very reliable because CGM gives you average HbA1c on its first page of the AGB report.
How do you decide a patient needs insulin or oral hypoglycemia?
So it all depends how they are presenting. If there is history of weight loss, they're very thin, then you need insulin. If the HbA1c is too high, then you need insulin. If the blood sugars are too high, you need insulin to control them. And then obviously you try to determine what type of diabetes they have. Have they presented with ketosis? Is their family history of type 1 diabetes? Have they had any recent immunotherapy? So it's all, there used to be a lot of simpler pathways, but now in my mind I think it's a lot more complex because we are seeing younger people with type 2 diabetes and very, like people in their 60s or 70s being diagnosed with type 1, previously known as LADA, but now it's called late onset type 1 diabetes. So you have to keep an open mind, you have to take a very good history, try and understand what's happening. If there's history of weight loss, they're very thin, their life is efficient. Does it answer your question? Thank you. Thank you so much.
So our next speaker is Dr. Abdullah Gujar. He is a consultant geriatrician at Walsall Healthcare NHS Trust with a strong commitment to advancing care for older adults. He serves as a mortality lead for the elderly care group within the Division of Medicine and Long-Term Conditions. Dr. Gujar has particularly clinical interest in Parkinson's disease and the peri-operative care of the older people undergoing surgery. He is currently developing a delirium follow-up clinic, an innovative and emerging model in clinical practice for elderly. He has led several successful fundraising campaigns on behalf of KEMCA-UK, raising over £100,000 in the past 3 years to support relief efforts for natural disasters and humanitarian causes. Please give a huge round of applause to Dr. Abdullah Gujar.
Assalamu alaikum, Martha. That was such a luxurious introduction. I don't deserve any word of it, I would say. As you already introduced me, so I work in Walsall Manor Hospital. It's right in the middle of the country, close to Birmingham. But I'll start my talk. Are you able to hear me from here without mic? Yes, I'm going to walk around and talk to you as well. So why I selected this specialty is perhaps I was impressed with dealing with my own family members, my grandparents, the older adults in my whole family. I always enjoyed their company, talking to them, listening to their problems. I think this is where my clinical acumen started developing to see, there is a gap, we need to do something about that. I'll come to that and I'll share some personal stories as well. But before that, I would ask the audience here, let's just move on to the next slide. If I ask the people here, just give a random guess. It's an aging population, not only in the developed world, but now it's in the whole world. If I ask you, just give a wild guess across the room, how many older adults are there in the whole world? So I would say about the age of 60, if we incorporate the low and middle income countries. So say how much, just no matter you agree with it or not. Okay. So when I was preparing for this talk, I asked AI. Everybody says you need to use AI more often and it can increase your productivity, and I thought I should do that as well. And the bottom picture came first, and it seems like there was a bit of accuracy. I could say that to look after older adults, there were some younger adults around there, and you could also see people of similar ages you need for their well-being, not only your immediate family members, but you need a good social circle to have your overall well-being. It's not just physical and health problem, it's also psychosocial issues which we need to address. Okay, so mainly I would share some stories, some principles of geriatric medicine, and then of course some soft skills for you as well. This is an 83-year-old gentleman. This is year 2010, very healthy, walks 5 to 10 miles a day, very active, looks after his grandchildren, no more problems at all, doesn't take any medicines, and one day just goes to toilet and notices that he's got blood in his urine. So big diagnosis, he's got cancer. Involves family, goes to the doctor, they run the test, and he's labeled as renal cell cancer, and there he's sent to a surgeon and they perform a nephrectomy on him. His whole life changes afterward, and then after nephrectomy he feels like he's got better. He goes back to his farming lands, he looks after cattle, enjoying all the things, but after a few months again he starts feeling some aches and pains in his body, and then he realizes, and after some tests, that cancer has come back. He's now not very mobile anymore, he's spending more time on the bed, and then aches and pains, the cancer has spread to the bones, backbones, so much pain that he can't tolerate it. He's got a grandson who goes to the doctor, the same surgeon. He was a medical student, and he asked the doctor that where can I get the morphine in Pakistan, in Sargodha. And you know what he was told, because there's no access to morphine, that you can only way you can find the morphine is by going to a drug addict. That was the answer. And unfortunately, he couldn't get the access to morphine, but still he remained in pain. Whatever the pain relief could be given to him, but eventually he spent more time on the bed and left the world eventually. So that gentleman was my grandfather, and that medical student was myself. So that was my own personal story. And that's why probably perhaps was one of the driving force for me to look into this area of practice as well. Another story. This is only last month. I was doing a weekend ward round in the hospital, and I entered in my ward, and the nurse in charge took me to side and said, "You need to see this patient straight away. They're not happy." I took my junior doctor with me, went inside. I could see he was sitting with his wife. Wife was anxious. I could see it non-verbally that they are not happy. You could see from the facial expressions. So I just went in there, introduced myself, and just listened. Just listened for a few minutes. What's happening? Just asked an open question, and they just kept on saying all the problems. The only reason he was admitted was he had a cancer, prostate cancer, which was metastasized to the backbone as well. Sort of similar, picture. And then the only reason he was brought into hospital was because he had anemia, and the doctor who saw him a day earlier, he promised that he would go home later on. And then, for some reason, somebody decided that he can't go home. So he spent a night in hospital, and that's how he was very unhappy about it. I asked what happened. He said, the doctor who came in yesterday, he said that they'll do the blood transfusion, and we would aim for a target of 70 grams per liter. And if that comes back 70 and above, we'll let you go. Of course, there's not much senior doctor cover. Later on, the resident doctor there repeated some bloods, and it came back as 69. And that's why they said, no, we need to follow the order as it is and let him stay overnight. And that was the only reason. So we did not think pragmatically here. We should have let that patient go home. So I, of course, apologized and told him what happened, and we should not do that again. But there's more to the story. He's again very high achiever, high performer. He used to play golf, and even when he was having chemotherapy, he would go and play golf. And he developed 3 joinery companies, and he was very successful in that. Unfortunately, as soon as he retired and passed on to his kids, that's where his cancer was diagnosed, and things changed afterwards. And I asked him, I'll let you go. This is what you want to go home, I wouldn't keep you in hospital. But of course, as a doctor, you would try to make sure they're taking a rational decision, but at the same time, making sure everything is in place. So you would look for whether they have access to palliative care medications, pain relief, and all this. As soon as I asked him, he said, "Doctor, I don't like morphine." His wife squeezed his hand and said, "Could you please convince him that he should take more morphine, because he's in pain and he never takes anything." And then I shared to him the same story of my granddad, and I exactly told him he didn't have access to morphine, and he died in pain, unfortunately, as a result. You do have access to it, why you're not taking it? He understood it. He asked me that, of course, I understand what where you're coming from, but this is my personal choice. I'm a very proud man, so I should respect that as well. So we said, fine, so you could go home. You do have access to the other palliative care specialist team in community, and they'll look after you. And not only we took that opportunity to have a chat, I came to know what he used to do, where he's successful at, what his priorities are, and what he wishes in the long run. He wanted to die at home. He wanted to die at home. His wife wasn't happy with that, but this is what the patient wishes are. So we need to entertain and make sure what patient wants. We even have to argue or in a healthy discussion where we have to even discuss that with families. They don't like it sometimes, but we need to always address what the patient's concerns are. So if you are going to learn anything, you go through these 4 stages. That initially, for example, when you were young, when you started learning the bike, so initially you don't know that you don't know. Okay, so once you start doing something for a period of time, then you start knowing that how much you don't know. And then you started realizing that that now you've started knowing a bit, perhaps, and then once it becomes more automatic, autopilot. For example, if you're asked to go and, drive the bike now, so you wouldn't think about it because it's already it's already wired in your brain, or what you call muscle memory. Yeah. So this is my typical day. So what we do is comprehensive geriatric assessment. So it's not just, I'll come back to it, so we'll look into every aspect of their care. So they are happy to talk about anything in their life. And then we manage frailty, which is like more weakness as they grow older. And what matters to the patient. This is what we were talking earlier. So making sure what actually matters to them. Yeah? And then multimorbidity is what Dr. Aisha was mentioning earlier, is that there are too many problems at the same time. So you have to manage, juggle through what is right for the patient, what we need to do, and what we do not need to do. So we need to be very clear. And then advanced care planning, which what I was talking about, that gentleman, that what would happen next. So we don't need to just treat them for right this moment and do not think about the future. So I always try to draw a line, tell them this is where you are in the future, this is bound to happen, what we would do. Do you want to come back to hospital, or if you want to do what you would like to do and what you would not like to do. So we want to make things clear. Like my granddad, I was telling you about the story, he was very clear. He would never want to have an NG tube. That was his wishes. So what we do is there's something called respect form. We put things on that form, making sure that all the wishes are recorded, as well as any medical decisions, they are also recorded on the same form. So that all the healthcare professionals which are involved in this, they know what you're coming from. So that you don't have to make the same conversation every time. And then of course communication is the key. The better you are at communication, especially with older adults, you would really know what they are telling you. Don't rush, never rush with older adults. Okay. So comprehensive geriatric assessment is mainly to improve your health outcomes, maintaining their independence, and preventing future hospital admissions and improving their quality of life. And I mentioned, as I said earlier, there are different professionals here. So not only you would look at the medical side, which you are good at as a doctor, but the functional aspect, that what they can do for their daily activities of daily living. Ask them what they do, they will tell you. And this is your opportunity to learn from them. I always reflect for myself what I need to learn from this gentleman, because they've got a wealth of knowledge of their whole life. You don't need to be rich and successful in one particular aspect. Like I was sitting with one of the older adults in the morning on my breakfast, and he told me something which I read few books, and exactly he was a reflection of that. He wasn't a very educated person, but I could learn if I would have just paid much attention to him. So use that opportunity. So we look at their cognitive function, memory, if they are confused. We will of course have a talk later on about that. Psychological aspects, look at their social setup, whether they are struggling financially, whether they need a social worker. Of course, based on which country they're working, there would be different logistical issues. Try to address them. Don't just think about medicine, think out of the box. Okay? And then looking at their environmental hazards, in particular, as you grow older and frail, your muscle strength goes down, you are at increased risk of falls, and you will end up having major bone fractures. So make sure that you have addressed their home situation. So there are special occupational therapists which can even do the home visits and try to see, which sometimes even we can ignore. They're very particular. They do measurements of home, where someone's coming from. They'll look at this mat is not friendly, there's a risk of fall there. So if somebody spends a lot more time in that specialty, they know what they're talking about, so we can involve these specialties to help with that. Okay. So with frailty, it's a distinct state where you reduce your body's reserves as you grow older. It's just the reserves have gone down, and only when a stressor comes in, for example, a major infection, or fall, or you just have been admitted to hospital, and then you would know that how frail they are, and now their function would decline, their memory would decline, their disease burden would increase. Okay. And then try to establish do's and don'ts. That I do a lot. And be very clear whether the patients like it or not, or the carers like it or not. And maintaining some realistic expectations. So making sure that what you want to do and what you do not want to do. But what we can do for patients who are older is making sure that you address their nutrition, optimize their medications, and making sure what matters to the patient we have looked at, and do advanced care planning. CFS I would skip because Aisha has already told in detail, and better than me, I would say. This is perhaps me without beard and dealing with all these multi-morbidities all the time. So you have to really juggle through making sure what matters to the patient and what is their main concerns. So make sure you address them. They might be having one major concern one day, next day it might be different, but make sure you've addressed that. Okay. Yeah, so this book, if you like to read, or even if you don't like to read, so just please do, I would recommend you to read this book. And what I do as my job, a lot of things I can see are more or less similar in this book by Stephen Covey, that be proactive, begin with the end in mind. For example, if you know what the investigation is going to do, then and if it's not helpful, why you're doing it in the first place? Put first thing first, yeah? Prioritize things. Think win-win about patient and for the medical side of things which you are suggesting to the patient. Seek first to understand. Seek first to understand. It should be 80% listening and 20% talking. It should not be more than that. Then that's how you would know. And synergize. Synergize means that you remember when you're sitting together and having a chat. There are two types of chat. One is like it's very formal, you meet somebody and go away. The other one is more formal or more informal, where you chat about things and where you end, somebody has already something to say, and then this is where you call it synergize, that your brains are connected. And sharpen this or improve your skill no matter what you do in your life. Few backside minors in the interest of time, I'll try to make it short. Making sure that you are sitting at the right eye level of the patient, and because most of them might have some arthritis, they're not able to even see upwards, so make sure you are at their eye levels. Hold their hands, avoid pain because they even have polyarthropathy in the hands. Make sure they really appreciate it, especially if they are anxious. This is one thing which AI cannot replace at all. That's human touch. So when you touch them, you can even rub their hand a little bit. They really feel calmed down, even if they've got acute delirium or confusion. They really respond to those non-verbal, cues which you are interacting with them with that. Holding hands and avoiding pain, I've already mentioned that. Okay, so can anybody guess which painting is this? Last Supper, yes, very good, that's amazing. So who's the central figure here? Jesus. Yes, Jesus. And who drew this painting? Leonardo da Vinci, yeah, that's the one. So wow, what is so prominent? So Da Vinci was amazing. He was an amazing artist. So just by putting a painting, he's telling you that there is somebody who's powerful, and he's in the center. Could you see his hands? One hand is upside down, and the other one is upside. The upside down hand shows authority, competence. The hand up means warmth. Yeah. So if you have a good combination of competence and warmth, that makes you charismatic personality. So your patients are looking at that, even if they are demented, they don't know. When you're presenting to patients, make sure you're well dressed. Some of my colleagues, they keep saying that there are, you could use medical scrubs and all this. So make sure you're very well dressed, you look like a professional. So they will look at that, the competence side of things. But when you embrace your hand, shake, you hold their hands, make sure all your competence, all their concerns are addressed, then they will feel, that warmth as well. So overall, they would rate you higher as compared to the other professionals. So there's some other non-verbal clues when you're listening to someone. So for example, if I'm talking to Dr. Professor Imran, and if I'm talking like that, it means I'm not that much engaged. As soon as he starts talking, and if I do that, our brain would just say that this person is listening. Okay, so the other issue, so this is like if I'm crossing my legs and I'm on the side, it means I'm not again engaged, my posture is not open. So it has to be fronted, and you lean as well, that I'm actually listening. It's the other way, you could use it, you can flip it across as well. If someone's talking too much, and then you can do that as well, and then they would disengage with you. So you could use these non-verbal clues in your clinical practice and in your personal life as well. Similarly, there are some primitive reflexes which you can see in demented patients as well. If you've got hand grasp reflex and palm mental reflex, so you could use that, engage with them. There's particular pain scores which you can apply in patients who have dementia or non-verbal patients. Okay, I'll skip this one. There's another writer, Sahil Bloom. He's a young writer, American writer. So he talks about 5 types of wealth. One is your, it starts with, it says time wealth, which is, for example, if your age is 90 years, it's 3 billion seconds. It's very limited time. So use that very wisely. If you're giving it to someone or someone's giving it to you, think it as money. And it would really be helpful that you're not wasting your time. So make sure that you're spending your time accordingly. Social wealth, that is your relationships with your spouse, your friends, family, your children, your grandparents and all this. So invest in them, that's so much important. To generate that wealth, you would have to do your investment from now, not late in the life. Mental wealth, that how controlled you are in your life, and you know what you're going to do, yeah? And emotionally you are more intelligent. Physical wealth, of course, if you don't have physical wealth, you cannot enjoy the rest of the things. And same is with financial wealth. You need to have a particular level of wealth to be free of and do the other things. But at one particular time, you should have a balance of all these, sometimes one more than the other, to say yourself that you are a wealthy person. So don't always when you're in money, but this time, but especially for our specialty, I would say particularly, think, and you would learn from your own patients that what is actually social wealth. Harvard Theory of Adult Development, it was 80-year-old study, and the outcome was mainly that healthy relationships, if you want to really make, they are the strongest predictor of the longer, happy and healthy life. And loneliness is harmful. It's an 80 years it was run, even John F. Kennedy was in this study. So you need to really look into developing healthy relationships. Okay, so I've got 3 take-home messages. Seek first to understand. No matter which area of practice you are in, especially with older adults, always make sure you've understood before you embark anything. And take holistic and patient-centered decisions. Whatever you have think, don't come with your own agenda. Let the patient speak for itself and let them decide. Patient-centered, more, shared decision-making with them, and then invest in building healthy relationships. That's my thought.
And it's a bit unnerving, but it's still very nice. So it's lovely to be here. So Clostridium difficile, you may have heard about it, or C. difficile. It's a public health problem. It's an infection that can affect the frail and the elderly. To carry on with today's theme, and it can cause a lot of morbidity and quite often a lot of mortality as well. So this was 2007 in the NHS, National Health Service of England. The Department of Health issued this kind of order or declaration that you have to measure some relatively new infection prevention measures. So the neckties, which are part and parcel of our work, especially as a duty doctor in the NHS, were to be done away with, and we had to wear short sleeve shirts, so it was called bare below elbows. So that was because of the increasing incidence of C. difficile as well as MRSA, which was increasing at a very rapid and alarming rate in the UK. The other preventive measures were introduced, hand washing and disinfection. So this was the background. There was an outbreak of a highly virulent C. difficile in North America to start with, in Canada and America, and the numbers started going up starting in mid to late 90s, and they reached a proportion which was very concerning for the frail and elderly population of Northern Europe as well as of the UK. And the numbers speak for themselves. In 1996, the number of incidents, new cases per 100,000 was about 31. By 2005, it had reached 84. This is the epidemiology in the UK. The national agency that keeps this number is called the Office of National Statistics, ONS. In 2007, there were over 8,000 deaths in the UK, and mortality was increasing to 85 per million in 2007. And as you can notice that it's a very serious infection in the elderly population, and the mortality is much lower in younger, healthier, fitter adults, and almost non-significant among children. So this is a graph over about 15 to 17 years, starting around about 2007 when the epidemic reached its peak. And it slowly came down after all these public health and hospital kind of behavior, day-to-day routine measures for prevention of infection were introduced. So it reduced to kind of relatively low level and acceptable level around about 2017 to 2020. And there has been an additional dip of an uptick. Hopefully this will have reached a plateau as well. So this is our own hospital. We are a hospital in northeast of England of about 250,000 population, and this kind of reflects the national trends, more or less. The case fatality rate, which was quite high in 2007, has gradually come down, as well as the overall mortality rate in people who get C. diff infections. So if you look at the epidemiological figures, in the community, the 5% of the adults in the community carry Clostridium difficile. Interestingly, if you are admitted to hospital, your chances of acquiring this infection, even if you're asymptomatic and just a carrier without any actual clinical symptoms, reaches about 50%. And this is quite often related to antibiotics. This is an interesting statistic because it also tells you that the healthcare professionals, including doctors and nurses, can also acquire this infection and carry it, although they may not be affected themselves because they are relatively younger and fitter, but they can pass it on to their patients who may not be able to tolerate it very well. So C. diff was first described, C. difficile first described in 1935. It is a gram-positive cytotoxin producing anaerobic bacteria. You are probably more familiar with gram staining than I am because you may have studied the microbiology more recently. It's a gram-positive bacteria with a cell wall. The important thing about C. difficile is that it produces spores which can be relatively resistant to anti-infection or disinfection measures, and it can be quite invasive, and it thrives in the presence of antibiotic treatment, which are given for other reasons. So just to go through some basic science, the bacteria carries a chromosome, which is DNA, and there is a particular locus of about 19.6 kilobytes of chromosomal region, and that carries the toxin-producing genes, which are called TCD-A and TCD-B. These are the main toxins. So TCD stands for toxin C difficile, so kind of French initials, and TCD-B, similar principle. There are another two genes in the same pathogenicity locus called TCD-R and C. R is the initiator of the transcription, so therefore it reinforces the toxicity and toxin production by the bacteria. TCD-C acts as a brake, and in the mutations in TCD-C can actually release that brake and increase the virulence. The CDD is another toxin which is outside of the pathogenicity locus, and it produces what is called a binary toxin, which can actually increase the ability of C. diff to attach to the colonic cells. This is more or less the same principle described, transcription of the B1 and A1, which are the toxin producing, A3, which are the toxin producing genes. And you can see on the left side the TCD-D, which is also another name for TCD-R. It starts the transcription. TCD-E in the middle, which I have talked about, is an area of the protein that is eventually produced, which helps a pore formation, which allows the bacterial toxin to get out of the endosome when it is ingested by the colonic cell. So this is the same process, so maybe I'll skip over this. This eventually is the polypeptide chain, the protein before it is folded and transformed into the actual active protein tertiary structure. So on the top of the slide, the TCD-A, you see various regions, and the similar principle is the toxin B as well. In the lower panel, in the B area, you can see various components of the toxin. The toxin binds with the cross to the receptor, which is as yet not fully identified on the colonic cell, that allows an endocytosis. So the whole toxin ends up in an endosome, which actually eventually allows the toxin to escape through a pore formation, and the end point is in the box on the right side. There is an enzyme called glucosyl transferase, the triangle that you see, which disables the GTP or guanine triphosphate associated energy mechanism of the cell. As a result, the colonic cell is starved of energy and undergoes apoptosis, and that is the main mechanism of the toxicity. So this is the passage of the C. difficile through the digestive system. When it reaches the stomach, the low pH, the acid environment of the stomach is actually protective, and it is said that the nitrites which are present in the saliva are converted by the acid in the stomach to reactive nitrogen compounds, which kind of act against the bacteria. If you give a proton pump inhibitor and reduce the acidity in the stomach, therefore increase the pH, it allows the C. diff to survive and reach into the small intestine. So the PPI can be a risk factor for the infection. In the small intestine, the bile acids that exist allows the spores to germinate and become the active vegetative form of C. diff. In the colon, the various things take place. The bacteria that exist, the commensal bacteria of the colon, are actually a protective factor. If you kill them through antibiotics, which are given for other therapeutic goals, that allows the C. diff to survive, because the protective mechanism of the colonic bacteria that goes away. The bacteria protect the bowel against C. diff through various mechanisms, including producing some molecules that actively attack and kill the C. diff bacteria, but also through using up and the nutrients, bacterial nutrients, and therefore depriving C. diff and not allowing it to thrive. But if the bacteria are sparse and killed due to other reasons, mainly antibiotics, then the C. diff gets a chance to thrive. So therefore, it is important to note that the normal microbiota, which is another name for the colonic bacteria, allows the bowel to stay healthy and protect against the C. diff infection. Through defensins, which are molecules which are produced, I mentioned, nutrients and biofilm. And secondly, bile acids, which actually do not help C. diff germinate from spore into the vegetative form. So this is the kind of typical iceberg. Many people get colonized and carry the C. diff asymptomatically, and eventually many of them clear the bacteria without suffering the illness. So there are some bacteriological techniques which are important in the nomenclature of C. diff. The top one is the pulse field gel electrophoresis, which is large DNA fragments. Then there is restriction endonuclease typing, which is the second one. Toxinotyping, you can actually identify the toxins and classify them, and ribotyping, which is the typing of the bacterial ribosome. So the explosive growth that took place in North America and spread across the world is therefore called the NAP1B1027, which is based on the PDFE-REA and also in the ribotyping. The quinolone antibiotics such as ofloxacin, ciproxin, they have been associated with a very high incidence of this outbreak. There is sequential typing as well, which is the evolutionary families of C. diff, which is also sometimes used. So this is the more clinical stuff, may be easier to understand and more relevant to our day-to-day work. So the severity of infection is based on the biomarkers, which are white cell count and creatinine. This, I guess, is unsurprising. Also, albumin, CRP, and fecal lactoferrin. So these are the definitions of different degrees or stages or severities of C. diff infection. Severe, where you have a high white cell count, high serum creatinine level. Complicated, C. diff can cause hypotension, ileus, megacolon, and may require a colectomy. And treatment failure, when people start deteriorating, with leading to multi-organ failure, and that can be eventually lead to a fatality. So most people recover, and but many of them have recurrence, which can be quite a difficult clinical problem to deal with. So this is the usual pathway. You get an infection, you can either clear it or you can start carrying it. And if you culture the bowel, the bacteria, you can find the bacteria. The toxin may be present, but it may not be causing harm or clinical manifestation. So it can start causing in some people pseudomembranous colitis or C. diff associated toxicity. some of them may recover from the acute clinical manifestation but carry it long term. Other people may actually recover completely, and some will have recurrence, which is the bottom right hand one. So this is the laboratory technique of culture. You can culture it in a specialized agar culture medium, incubate for 48 hours, and confirm the identity of the colonies by laboratory means. So this is a gold standard against which all the other laboratory techniques are compared. The actual bacterial culture. So this is the called cytotoxic assay. Vero cells are actually kidney cells. I think it is simian monkey kidney cells which are used in the laboratory as a and they are kind of immortal. They can be perpetuated. The C. diff can cause their infection and destruction, but if you have antibodies against C. diff, they will protect the cell culture. So that is how the CCTA or the cell cytotoxicity assay is quite useful. It tells you whether or not in a particular sample there is a toxin present which is active or not. So this is the comparison of various laboratory techniques. I've talked about cell culture and these like cytotoxicity, assay CCTA, the first two cells on the left side, and then the GDH, the glutamic dehydrogenase. That's a very useful and quick and easy technique. It's based on immunoenzyme assay, so EIA. So it is a very quick and easy test. So this enzymes is involved in the energy metabolism of C. diff, and it is very well preserved across all the living beings. Actually, we have an equivalent which is also called as CDH. So it is a wonderful unity of the evolution of life, that's from bacteria to young doctors, Homo sapiens, and medical students. We have the same underlying mechanism of energy extraction. So, but GDH in bacteria is kind of identifiable because of its different, slightly different nature with the enzyme assay. So usually the way to for a quick diagnosis is because cell culture takes very long. What you do is you do a GDH assay, which is quickly available, and if it is positive, then you can do the cytotoxin assay, which is also quickly available. Another one is the last one on the list, which is called nucleic acid amplifier test, which is a PCR test, which can actually detect the toxin genes in C. diff. Although the presence of toxin genes may not actually mean that the bacteria is actually producing toxin actively and causing C. diff infection. So, so the usual way to diagnose is two-stage test. You can either do GDH or PCR, and that will tell you whether or not bacteria is there, and then you can do an enzyme immunoassay for the toxin, and that gives you the answer, usually on the same day. So this is the practical way to approach. Regarding treatment, it was found that the antibiotics are associated with pseudomembranous colitis since 1950s, and vancomycin was actually the first antibiotic that was used to treat it. It was very effective. Since then, a number of other antibiotics have become available and have been tried. Metronidazole has been tried. It became popular in the 1990s because it was thought that its efficacy was as good as vancomycin. But then it was found later on with the new resistant C. diff emerging that metronidazole actually can be effective in milder infections, but had a higher rate of recurrence after the patient was discharged. Fidaxomicin is relatively new. It is actually very, very effective, and usually the first line, at least in severe infections. And there are other antibiotics which are used, but not as first line. Rifaximin usually used in recurrent infections and what is called a chaser. So you give a course with either fidaxomicin or vancomycin, and then you can do a few weeks of rifaximin in a reducing dose. So the first line remains vancomycin or fidaxomicin, and for recurrence as well, you can give either of these medications. And for fulminant C. diff colitis, you can give vancomycin in addition with intravenous metronidazole. The metronidazole, almost all of it is reabsorbed, is absorbed through the small bowel, and the actual quantity that is available in the bowel comes from the blood circulation. So this is the recurrence treatment. As I mentioned, you can use either vancomycin or fidaxomicin. So FMT, fecal microbiota transplant. So this is a relatively new and slightly bizarre treatment. Do you know what it is?
Yes.
So speak up, please. Sorry, I'm so deaf. Anybody raise your hand and tell me what FMT is? Yeah, go ahead.
Take the fecal matter and then kind of introduce into the person's gut.
Yeah. Basically, it is human stool given as treatment, getting it into the digestive system by various means, and that the principle is that you give healthy bacteria and restore the population of healthy bacteria in the colon. So it seems so off-putting, but it has captured the imagination of the British patients and general public. It is obviously because of its bizarre nature. It was mentioned in the media as well. So usually the patients are very receptive to this. So obviously it is a relatively new treatment to treat this problem, especially severe or recurrent illness with C. diff. Obviously the actual principle is very old and has always been available, but the technology and the understanding is relatively new. It has been used for centuries. It was anecdotally used in World War II by the German troops. I'm not sure why it should be German only, maybe it's just the British propaganda. So they were using camel feces to overcome the severe bowel infections that they acquired in Africa. So it has to be regulated. Initially, people who gave this treatment acquired the donation of the feces from usually a close relative, usually a spouse. But there are obviously issues which can be concerning, for example, transmission of infection. So there is therefore any donor who is willing to give a part with their possession of feces are very carefully screened. They are given, they undergo all the tests for viral hepatitis, for example, hepatitis B and C, also HIV and other transmissible diseases. So they should be physically healthy, not have a chaotic lifestyle such as IV, drug use, etc. They should not have inflammatory bowel disease or even IBS. So we actually started this treatment in our hospital a few years ago in people who were very ill, frail and had recurrent disease. So we acquired the actual treatment material from Birmingham. So there is a stool back there, believe it or not. It is frozen stool which is transmitted to the northeast, which is about, I think, 150 miles, about 200 miles on a motorbike. By the time the treatment arrives, it is not frozen anymore, it has thawed to a relatively softer consistency. And so these are just the figures to tell you the scale of the problem. in our own local hospital, about half to one-third of the patients actually die, those who get the illness. So this is how it is prepared. So we give it from the top end. You can give the treatment from either end. You can give it through a colonoscope and instill it at more proximally in the large bowel in the colon. But you can also give it through a nasogastric or preferably a nasojejunal tube. So we put a tube down through the nostril into the small bowel, far down into the duodenum or most preferably into the jejunum. And the stool is blended in actually a blender. This is the normal kitchen variety blender in either water or saline, so that it is of the liquid consistency, able to go down the narrow caliber NJ tube. So NJ tube is basically to make sure that it is far down into the small bowel and reducing the risk of vomiting, which obviously can be hazardous and quite unpleasant as well. So this is the kind of protocol which I've just described. Just a quick patient summary. 79 years old woman, multi-morbid, as I've described, ischemic heart disease, CKD, diabetic vascular heart disease, and hoist transferred, so very frail, not able to mobilize on her own. So she had a recurrence 7 times, which was obviously a great strain on her own personal quality of life, but also on the healthcare resources in the hospital. Eventually, she received a fecal microbiota transplant for food treatment, July 2021. She was seen about a year later, 2 episodes of diarrhea, 1 course of vancomycin, but no further hospital admission. So this was a great relief for her. So fecal transplantation is about 90% effective, which is amazing. I think for any kind of treatment that exists anywhere in the world, this is hugely effective and obviously very cheap as mud, you could say. We have about 8 to 10 patients per year at the QE in our hospital. So this the rest of the gibberish is regarding the funding, which you probably don't need to know. So there are newer treatments emerging, which is vaccination immunoglobulin, especially convalescent people who have recovered. They probably have antibodies which you can use, but actually you can construct immunoglobulins against toxins in the laboratory as well, like monoclonal antibodies. Probiotics have been used and they've been found useful, but the evidence base is not very strong and they're not currently available regularly on the NHS. Probiotics are usually 2 kinds of healthy bacteria, lactobacillus and Saccharomyces, which is a yeast, and also I think bifidobacterium, which are made into a preparation into a capsule, which is obviously much more pleasant and acceptable to take without all the mess that are going through all those difficult preparations. But the evidence base for this is a little bit poor at the moment. Prevention is just public health measures, disinfection measures and protection measures, and that is the reason that the incidence in the UK has declined steadily over the past 20-25 years. And I think it's very relevant to Pakistan as well. I think the elderly population is much smaller in absolute numbers in Pakistan, but the use of antibiotics, especially unsupervised and unregulated use of antibiotics, is very, very common. So I think this is a public health situation that will arise if it has not arisen already, and you should be prepared for it. So thank you very much.
No, just one line I would like that. His upcoming book is titled Secrets, The Stories of Psychiatry from America and Pakistan. Please give a huge round of applause.
So, Rajan, can you hear me okay? Back. So first of all, a very warm welcome to our friends from the UK. Dr. Abdullah actually made my intro a little bit easier with the talk he was giving, and then Dr. Athar gave us an interesting perspective on all the other thing. Dr. Aisha, I listened to part of the talk. Thank you so much. सबसे पहले ये बताएं कि who is an elderly person. So when Professor Shehzad, Dr. Tabinda, Professor Bilkis here, Dr. Tareen, Professor Naki, Professor Merin Said, हम लोग करते थे ना, Professor Imran Khan, when we were sitting in these seats, everybody over the age of 30 was elderly, right? Then we passed our MBBS and then we went into our post-graduation and we started, doing that, and then we became consultants, and then everybody over the age of 40 was elderly. Right? Then we became medical teachers and we became assistant professors and all this, and then everybody over the age of 50 was elderly. And now we are nearing the end of our, teaching careers. I really don't want to say over 60 is elderly anymore. So it's just perspective. It keeps moving. The goalpost keeps moving. I wanted to show this just to sort of point out the existing family structure in Pakistan. This is the typical way that we still live, more or less, right? We have two elders. We have the children and then their children. My son Hamza, mashallah, is studying for his masters in the US. But I just thought this. Now this family structure is very much in transition, even here in Pakistan. In the UK, it doesn't exist in this form, hasn't existed for a long time. But even here, especially in the urban areas, this family structure is changing very quickly. And so the automatic support that elders had of a large family is increasingly beginning to lessen. So just keep that in mind as we go ahead. What does that mean? What does that word mean? The reason I put that there is because, we are still, अभी हम आप नौजवानों की मजबूरी है, क्योंकि हम आपके अफसर हैं, so called. Lekin once we transition away from this role, and I can already sort of see it happening, we increasingly begin to get invisible. Your concerns don't really match our concerns, what you think about, what you do. So this happens with me also. When I see someone in clinic, I'll often find myself turning toward the family member because sometimes they can't hear too well, the elderly person. Sometimes they can't see too well. Sometimes they can't understand me because they've got some cognitive issues. So I find myself talking to the son or the daughter or the family member as if they're not even there. Right? What does that mean? Dr. Abdullah pointed to this. It's not just a matter of losing a loved one. We were just going around the campus, Professor Naki and I, looking at some of the halls. And then we got to a place where there were stairs. And our VC Sahab, mashallah, may God give him long and healthy life, bounded up the stairs. And Naki Sahab said, let's take the lift. I've got knee problems, so do I. So all of these things are something that you take for granted when you're younger and that you start losing as you get older. And that becomes a part of who you are. But that may be incomprehensible to the people sitting in the back. What's wrong with that? What's wrong with your knees? Nothing. Well, my knees hurt a lot. My back hurts a lot. So there is also that. In addition to the losses, friends and family members and people that you are close to, all of that, there's also the physical integrity that begins to decline as you get older. So, my father, may God bless him, was a psychologist. He was very against medicines and he thought psychiatrists were ignorant pill pushers, which most of us are. So he was very against it. So लेकिन जब उन्होंने तीसरी दफा मुझे आगे कहा कॉन्वर्सेशन नहीं यार मैंने बड़ा ही डिप्रेशन होता है मैंने कहा बिल्कुल दवाई खा लो अच्छा दे दे. So because of course he was my father and all this, so he सारी उम्र उन्होंने हमें बताया था ये दवाइयाँ ये सारी चीजें जो है. But just because someone's old doesn't mean they're sad because they're old. They might have depression, they might need treatment for it. And they might do really well with treatment. ये तो बात होगी अभी थोड़ी सी You know, I see this in my practice also. दिन में सो जाते हैं, रात में नींद नहीं आती. दिन में इसलिए सो जाते हैं, कुछ करने को नहीं है. काम तो खत्म हो गया, रिटायर हो गए, बच्चे काम पे चले गए, छोटे बच्चे स्कूल चले गए. So I say to the family members, इनको engage कर ले, पर उनके अपने काम है. Even in a close family system, even in a joint family system, everybody is busy doing something. So this becomes almost like taking care of a young baby. The older they get, the younger it feels. Except different. Because with babies, you know that they'll eventually grow out of it. And here is a different perspective. ठीक है ना? This is what my dad used to call it. ये उनका कमरा है यहाँ पे, ये यहाँ पे मेरा कमरा है, इस तरफ एक ही घर है. And he used to say, यार अजीब मुसीबत ही की है, कहते तन्हाई. He's right there. और लोग आ रहे हैं, जा रहे हैं, अंदर हो रहे हैं, बाहर हो रहे हैं, नौकर, रिश्तेदार. That's what he used to call it. I thought I'd put it on there. और फिर I think Dr. Abdullah also hinted that maybe the elderly are all right. Plus in this culture, I mean, there, the elderly, you're sort of respectful and you're deferential, and then people of his generation, I mean, the mental health part was just not something that was talked about. You just got on with it. ठीक है ना? What's the point of treatment? Well, it makes a huge difference. There's all kinds of evidence now that the brain continues to grow, continues to change, continues to modify itself, continues to, it's a slower process, but treatment absolutely helps. Not just for the mental health part, all kinds of physical morbidity will also improve if you treat for mental health. Not treat necessarily, but support mental health. If you don't overlook mental health. This part here is still yet preserved in our country. It's changing. It's easier. When you all live in the same roof, live in the same city, the same community, it's easier. हमारे UK से दोस्त आए हैं, they've seen a different perspective. They have to fly all the way here to see them, or they have to fly them all the way there. Which old people do not like me. Old people like me do not like change. We like our familiarity. So that becomes when you're separated by one continent. In my case, when I was in US by two continents, that becomes even harder. Why? It's easier now with the screen and the video calls and all this. But of course, इतनी अच्छी बात की. अगर आप उनका हाथ पकड़ के उनको touch कर लेंगे, तो that's the whole thing. You can't do that through a screen. Can't do that through a video call, right? All kinds of evidence for this. अच्छा, again, लोग तो बहुत सारे हैं. अब मुझे इसमें लोग तो हैं, मैं भी यही हूँ, मेरे बच्चे भी यही हैं. But it's the feeling of being alone. His parents are gone, his brothers and sisters are gone, his friends are gone. And we are all there, but it's not the same thing. Those are the losses. उससे फिर तनाई, मुझे बात करें क्या है तनाई, सारे चले गए. बस ही दे गया, हाँ ठीक है, तुझे बैठो. आप अच्छा बैठ के फिर चले, तो बैठे नहीं मेरे को. फिर चले. और मुझे कॉलेज जाना है, यूनिवर्सिटी जाना है, क्लिनिक जाना है. अच्छा जा मेरा, शाम को आइए. So if you have this complaint, they're coming back repeatedly, इधर दर्द है, उधर दर्द है, ये नहीं ठीक है, वो नहीं ठीक है. Check and see what's going on at home. Dr. Abdullah made my talk much easier. He talked about all this. Check and see what's going on at home. Even this is hard to do in a rush clinic. With the elderly, you have to take a lot of time because there's a lot of issues going on. So if you're going to see somebody over the age of 60 or 65 or 70, make sure you budget enough time to get into all this. Just writing a prescription and sending them away is useless. It's totally useless. Don't do it. Might as well not do anything. The prescription से और उनको side effects हो सकते हैं, मसला हो सकता है. We talked about this. They might not say. In fact, they often will not say, "I'm depressed. I'm sad." This is what they'll say. This is very useful. This is very, very common. And why do they say this? Because they feel it's actually true. Now the flip side of that is, एक दफा मैं बुक तक बैठा हुआ, आई बातें हो रही हैं जो कुछ भी है. तो we just made a joke. मैं क्या तुसी करते क्यों सारा दिन? Something. We were having a friend. यार तो हाल है, बच्चे पाल रहे हैं, सारे देख रहे हैं. So as I reflected on it, I mean, his role was largely symbolic. He didn't actually do anything, but he was there for all of us. So that does matter. But at the same time, I mean, they don't go to an office, they don't work that way. So sometimes that feels, that feels like they're useless. That feels, this is what they're unhappy about. यहाँ पे आपने फिर डिप्रेशन का ख्याल रखना है. There's all kinds of wonderful, for our non-psychiatric colleagues, wonderful small screening tests. Takes 1 minute, 2 minutes, 3 minutes. You can even do it very easily do it in a busy medical clinic. Just do a screen. If they're depressed, treat them. Or send them to us, we treat them. We hear this all the time, right? I don't know what it's like in the UK, but our elders say this all the time. My grandmother used to say it way back in the day. I didn't understand it then, now I understand it because I'm close to there now. You see, we're both banna. When someone has sort of formal dementia, they've developed dementia, and they're agitated, they're fighting, they're not sleeping, they're not eating, they're angry, don't just medicate them. Don't do that. इन्होंने अभी वही बात की थी. Just बैठ के सुन ले, मसला क्या हो रहा है, तो दर्द हो रही है, bladder का मसला है, but again, that takes time, takes patience. They can't communicate because they lost that skill. You have to sit with them and you can't rush them. And in a place like Mayo, for instance, in an OPD where you're seeing 150 patients in 4 hours, it's very difficult to do. But as I keep telling my residents, if you don't have the time, then wait and bring them back another time. Don't just write a prescription and send them away. That's going to hurt them more likely than help them. This is a very simple question to ask. I ask this all the time in my practice. Not just in the elderly. What is it that's bothering you more? What can I help you with most? Today, tomorrow? So you can prioritize what you want to focus on. It's pretty simple. And then this is important. The family wants them to eat when everybody eats. Maybe they're not hungry. They're not hungry because they're sitting around, they're not walking around all day. The family wants them to take a bath when they want them to take a bath. Because the Nokrani is there at that time or the Nokrani is there. They won't करना चाहते उसमें. So don't force them into dependence. This is what they fear. Give them some sense of agency, some sense of independence. आपने शाम को नहाना ले, सुबह को नहाना. अभी नहीं खाना, बाद में खा ले. That becomes a little bit more difficult for the household routine. भी खाना इतने में लगता है. अब खाएं. नहीं खाना तो बाद में खा ले, कोई बात नहीं. And then, in our culture specifically, the feeding part is very important. We love to feed. Right? Yes, you have to eat. Otherwise we get offended. You have to. So then we खा नहीं रहे, कमजोर हो रहे हैं. खा नहीं रहे, डॉक्टर साहब खा नहीं रहे. 75, 80, 85 years old. मैं दिन में 3 दफा नहीं खा सकते वो. और उसका आसान तरीका उनका वेट कर ले. Weigh them once a week, twice a week. And if it's maintaining, then they're getting enough calories. Don't worry about it. But then this is a cultural thing. Doctor साहब ये खाते नहीं, कमजोर हो रहे, खाते नहीं. I think this is the next to last slide. Now I understand. Now that I'm the cusp of old age, we all are. Well, not everybody in the front row, so Maiya is pretty young. लेकिन हमसे बहुत सारे लोग front row में बैठे हुए. Now we understand what the worth of the elderly is. Because we've also gone through some losses. Yeah. If you're lucky, you'll get there. But then, and somebody mentioned it, Athar Sahib was saying, at the moment, the proportion of the elderly in this country is very small. And our young population is still growing. But in 20 years, it's going to be the other way around. What the Western world has been facing for a while, what China is facing now. So it's important that we plan for it. And when we get to that age right now, when you get to that age, and boys and girls, I assure you, you can ask each and every one of these people who I just pointed out. It comes quicker than you think. Quicker than you think, just like that. Mom, बैठे हुए थे? अभी तो आ गए. When did that happen? It happens in the blink of an eye. It really does. आपको ये नहीं आना. I know हमें भी नहीं आता था. जब हमें कहते थे हमारे साथ. But on Now this part, just take my word for it. So I thought I'd end on this. I'll show you a personal link to the UK. For the girls in the audience, I didn't have time to Photoshop out the cigarette. But this is the 1950s. This is an English woman. Her name is Alice, who also happens to be my nanny. और वो इंग्लैंड से थी. ये नहीं आप लोगों ने देखना, मुझे ड्राइविंग ना मैं इसको काट देता. 50s में 60s में कभी किसी को पता नहीं था कि सिगरेट कितने हार्मफुल होते हैं. So kindly इसको ignore. This was back then, yes. She passed away in 2002 at the ripe old age of 93. She's buried right there in Hall. So I thought I'd end on this note. So welcome to our friends from the UK.
मैंने सोचा ही था कि मैं आपको स्लाइड दिखाऊं. मैंने सोचा कि दिखाने की जरूरत ही नहीं, लेकिन फिर भी अतमाम में हुज्जत करना है क्योंकि इन्होंने कहा है कि जरूर सुनाना है. सो एज अ ग्राउंड रूल मैं सजेस्ट कि जिन्होंने अभी तक भी बैठे हुए अपने मोबाइल साइलेंट नहीं किए बनाएंगे, क्योंकि कई दफा ऐसा हुआ है कि बड़ी ही अच्छी ट्यून सुनाई दी है, दिल ने चाहा है कि ये बंद हो जाए और आपकी ट्यून ही चलती है. सो इस वजह से अगर उसको साइलेंट कर लें तो
What will your last 10 years look like? Will you be quick enough for a game of tag with your grandchild? Strong enough to embrace every moment? Will you grow old with vitality? Or get old with disease? It's time to decide. The average Canadian will spend their last 10 years in sickness. Change your future at makehealthlast.ca.
राइट देन जो मेरे क्लोज में लोग वो ये बात जानते हैं कि जिस घर में मैं रहता हूँ वो एक जॉइंट फैमिली है. उस जॉइंट फैमिली में मेरे वालिद साहब माशाल्लाह 8 भाई, उनकी एक बहन और उनके बच्चे मुलाजमीन वगैरह. Now this makes the count somewhere around 70 plus living in the same house. और जब तक मेरे दादा और दादी हयात थे तो मेरी किसी ताई या किसी उनके बच्चे को जरूरत नहीं थी कि वो उनके कहे हुए को टाल सकें. There was a time जिस पर बेल बजेगी और सबको मौजूद होना होगा, अपनी फिक्स्ड सीटों के ऊपर बैठना होगा. लेकिन टाइम चेंजेस. बताने का मकसद क्या है? बिफोर इवन बिकमिंग अ डॉक्टर, being a student, मेरे दादा उस वक्त 90 प्लस थे. I'm talking of mid 80s. और मुझे याद है कि उन्हें प्रोस्टेट था और सिस्टोस्कोपिक सर्जरी नहीं होती थी. तो मुझे ये बताया गया था कि उसका तरीका यही है कि उन्हें हर 15 दिन के बाद एक फोलिस कैथेटर डाला जाएगा. और मुझे एज अ टेक्निकल हेल्प, क्योंकि मैं फर्स्ट ईयर में था मेडिकल कॉलेज में, तो मुझे खड़ा कर दिया जाता था. Within few months time, situations ऐसी arise की जिसमें आप डॉक्टर साहब नहीं आ सकते हैं, तो मुझे कहा गया कि अब तुम ही डालो. So gradually with the passage of time, ये छोटे मोटे प्रोसीजर करना, यानी 3rd year 4th year में मुझे याद है कि मैंने 3-ray कैथेटर भी डाले हुए हैं. मैंने सेलाइन से वॉश भी किया हुआ है जब उनको कोई ब्लीडिंग शुरू हो गई है. लेकिन ये वो चीजें हैं जो आपकी जब, और ये मेरा इंटरेस्ट था कि जब मैंने पहली बार एल्डरलीज को देखना शुरू किया, तो अब आप इमेजिन करें कि मैं आज जब बात कर रहा हूँ तो उनमें से सिर्फ 2 हयात हैं, लेकिन जितने भी थे बाकी के ग्रेजुअली जैसे जैसे वो दुनिया से गए हैं उनकी ज़रूरियात थी। और जो मेरा एक्सपीरियंस पाकिस्तान में रहते हुए था वो ये था कि अगर फैमिली सपोर्ट इनको न मिली होती तो इनकी लाइफ मिजरेबल होती। लेकिन यूके में ये सिस्टम बिल्कुल फ़र्क था, जैसे अभी डॉक्टर अब्दुल्ला ने या डॉक्टर अली ने मेरा काम आसान कर दिया। तो Pakistan's elderly population is growing, geriatric care is pressing issue, and evidence-based solutions are needed. Now, demographic shift suggests that 6.5% of Pakistan's population is 60 plus and projected to reach 15% by 2050. Shehzad is here, he's a public health person, he knows better than what I am telling, and I am hopeful to get some answers from him at the end of my presentation. So increased burden on healthcare system is tremendous. So issues क्या होते हैं already amicably pointed out हैं, non-communicable diseases, mental health issues, and osteoporosis and fractures common. मुझे as acute on call मुझे याद है कि जीरियाट्रिक पेशेंट्स जो होते थे जो फ्रैक्चर हिप के साथ आ जाते थे उन्हें विदिन 24 आवर्स खड़ा ना कर दिया सर्जरी करके तो इम्कान ये होगा कि अब ऑन गोइंग लाइफ में जो टोटल एक्सपेंडिचर उनके ऊपर होगा वो बढ़ जाएगा। तो हॉस्पिटल्स की प्रायोरिटी होती थी कि ये एल्डरली है, इसको जल्दी खड़ा करना है, इसका हिप रिप्लेस करना है, इसको जल्दी जाके देखो इसको क्या करना है, ये फिट है कि नहीं। सो करंट स्टेटस क्या है ऑफ जीरियाट्रिक केयर? Limited Pakistan, limited geriatric care services, few trained geriatricians, and inadequate social support. And I'm very thankful कि अभी अब्दुल्ला साहब ने बात भी की है, इससे पहले शफीक भी मुझसे कह चुके हैं। I'm happy कि अगर यूनिवर्सिटी इजाज़त दे तो हम एल्डरली से रिलेटेड कुछ बेड्स और एक हाइब्रिड किस्म का सपोर्ट सिस्टम अपने डिपार्टमेंट में कम से कम शुरू कर सकें ताकि हम उसको एज अ मॉडल प्रेजेंट कर सकें ताकि इसको एक्सटेंड किया जा सके। इंटरनेशनल बेस्ट प्रैक्टिसेस क्या हैं इसको भी मुझे बताने की जरूरत नहीं है, ये ऑलरेडी आपको कुछ चीजें पता हैं और कुछ मुझसे पहले वाले बता चुके हैं। सोशल सपोर्ट में फैमिली प्लेज अ क्रूशियल रोल एंड आई थिंक पाकिस्तान इज ब्लेस्ड। उसकी वजह यह है कि मुझसे ज्यादा आप उन लोगों से पूछ लीजिएगा जो अपना बहुत ज्यादा जिंदगी का हिस्सा या वहां गुजार चुके हैं या अभी भी गुजार रहे हैं कि वहां पे बूढ़े का मतलब ये है कि अगर 4 दफा से ज्यादा केयर की जरूरत है तो वो नर्सिंग होम में जाएगा, यानी 4 दफा से ज्यादा विजिट की जरूरत है घर से। सो इसका मतलब क्या है, वो अपना घर में नहीं रहेंगे और अब बच्चे उनसे मिलने के लिए कब आएंगे जब उनको फुर्सत होगी। ऑल्दो उनमें बहुत अच्छे भी हैं लेकिन ऐसे भी हैं जो इग्नोर करते हैं। तो मुझे याद है मेरी एक एसएचओ थी, आई डोंट वांट टू नेम, लेकिन मैंने मुझसे कहने लगी कि डॉक्टर साहब हमारा मैं इस वीकेंड पे लॉन्ग वीकेंड के लिए पेरिस जा रही हूँ। तो मुझे क्योंकि मैं नया गया हुआ था तो मेरा ख्याल था कि शायद ये अपनी वालिदैन के साथ जा रही हैं, जैसा मैंने उनसे कहा कि सो व्हेन आर यू लिविंग विद योर पेरेंट्स, तो जवाब मिला नो आई एम गोइंग विद माय बॉयफ्रेंड। और उनका कहने का मतलब ये था कि मैं पूरा हफ्ता, यानी उन्होंने 9 दिन हो गए ना, 5 दिन 2 वीकेंड सैटरडे संडे, तो वो 9 दिन हो गए उनके लिए, तो वो 9 दिन उन्हें पेरिस में गुजारना थे और वो मुझसे इसलिए बता रही थी कि मैं कवर रखूं। जब मुझे वैसे ही ख्याल आया, मैंने कहा कि आई थिंक योर पेरेंट्स लिव फार ऑफ, जवाब मिला नहीं, they are just 20 minutes drive from here. अच्छा, so when did you last meet them? जवाब मिला last Christmas. So अब मैं उसके बाद इतना यानी अजीब महसूस कर रहा था। You can just imagine कि माँ बाप 20 किलोमीटर दूर रहते हैं या 40 किलोमीटर, लेकिन ये साल पहले मिली थी और अब जा भी रही हैं जब छुट्टियां हो गई हैं। लेकिन मैंने उनसे कहा कि it's really nice, do let me know about your feedback so that I can decide my weekend, छुट्टियां मैं वहाँ कैसे गुजारूं। Social isolation, exacerbate health issues and community-based initiatives are needed. So policy initiatives पाकिस्तान के क्या हैं? नेशनल सीनियर सिटीजन पॉलिसी 2018 में बन चुकी है, लेकिन अनफॉर्चुनेटली ये एक ड्राफ्ट है। इम्प्लीमेंटेशन के लिए जिस चीज की जरूरत है वो पूरे पाकिस्तान को जरूरत है। सो हेल्थ केयर सिस्टम के चैलेंजेस क्या हैं? लिमिटेड केयर सर्विसेज, inadequate training for healthcare professionals and insufficient resources। इसमें से क्या हम एड्रेस कर सकते हैं? I would definitely like कि इस मीटिंग के एंड पे जब Q&A करें तो हमें वो एक कोई मॉडल ऐसा जो हाइब्रिड हो वो बनाना चाहिए कि इसको हम कैसे बेहतर बना सकते हैं। हमारा ज्यादातर वार्ड, अभी डॉक्टर अब्दुल्ला से मैं कह रहा था कि हमारे मेजॉरिटी वार्ड्स तो एक्यूट मेडिकल वार्ड्स हैं और एवरेज 60 बेड हैं अगर तो वो डबल ही होते हैं हर इमरजेंसी के बाद। तो हम कैसे मुमकिन है कि उन्हें 2-2 हफ्ते रख सकें? वहां तो आप इसलिए रखते हैं कि हुकूमत उन्हें सपोर्ट कर रही होती है। सो हमारे पास कोई नर्सिंग होम नहीं है कि हम उन्हें रेस्पाइट में या नर्सिंग होम में भेज सकें। हमें तो वहीं उनका क्विक ट्रांजिशन चाहिए, उनके केयर्स की एजुकेशन चाहिए और वो तरीके चाहिए जिससे हम उनको बेहतर से बेहतर बना सकें और एक मॉडल पेश कर सकें। सो जीरियाट्रिक केयर मॉडल्स बहुत सारे हैं, मल्टी डिसिप्लिनरी टीम्स हैं, कम्युनिटी बेस्ड केयर्स हैं, इंस्टीट्यूशनल केयर ऑप्शंस हैं। यहाँ नहीं है माइंड यू, जहाँ हैं वहां से हमें हेल्प चाहिए। सो और ये बेशुमार चीजें इसमें कि ओल्डर पर्सन के लिए नर्सिंग, सोशल वर्क, मेडिसिन, डेंटल मेडिसिन, फिजिकल थेरेपी, फार्मेसी। सो इसमें से कुछ प्राइमरी केयर की हैं, कुछ फैमिली की हैं, कुछ केयर ड्राइवर्स की हैं और कुछ कम्युनिटी सपोर्ट्स हैं। एविडेंस बेस्ड इंटरवेंशन क्या कर सकते हैं? एक्सरसाइज प्रोग्राम्स, कॉग्निटिव ट्रेनिंग प्रोग्राम्स, मेडिकेशन मैनेजमेंट। एक बड़ा अच्छा पिछले दिनों मैंने फेसबुक पे इश्तिहार देखा कि एक लड़का जो अपनी माँ को सुबह बुखार और खांसी में देख के परेशान था, आपने से कुछ जरूर देखा होगा, ये इंडियन इश्तिहार था कि वो ये देख के परेशान था कि मुझे तो काम पे जाना है, मैं लेट हो रहा हूँ। और जिस वक्त वो काम पे था तो वहां दिखाया कि वो फोन कर रहा है उनको कि मैं वहां से जल्दी छुट्टी लेके घर आया है अपनी माँ को डॉक्टर के पास ले जाने के लिए। एंड देयर शी ऑलरेडी हैड अवेल्ड अ टेलीफोनिक सर्विस, टेलीमेडिसिन, और उसको वो मेडिसिन भी ड्रॉप की जा चुकी थी उसकी माँ को, एंड शी वाज ऑलरेडी फीलिंग बेटर। इट वाज जस्ट अ टेलीफोन कॉल। So technology and aging, telemedicine for remote monitoring, mobile apps for health tracking, and digital literacy for elderly. These are all way forward. And family support is most important, as I said, कि caregiver की education, respite care services, and financial assistance. These are all equally important. Community engagement कैसे की जा सकती है? Age-friendly community initiatives. इसके अलावा वॉलंटियर सपोर्ट प्रोग्राम है। फॉर दिस ये वॉलंटियर सपोर्ट वाला जो है ना, ये तो इतना आसान है मेरे ख्याल से, और इसके लिए सजेशंस भी हैं। मसलन आप में से कितने थे जिन्होंने एनसीसी करके 10 नंबर लिए थे? हाथ खड़ा करेंगे ओल्डर लोगों ने। क्या ऐसा कोई सिस्टम नहीं हो सकता कि बच्चों को ज्यादा मिले थे? सो आप मुझे बताएं कि क्या ऐसा कोई सिस्टम नहीं हो सकता कि जो मेडिकल कॉलेज में दाखिल होने के लिए आ रहे हैं फर्स्ट सेकंड अपने एमडी कैट से पहले उन्हें 2 महीने लगवा दिए जाए कि वो ये करेंगे सोशल सर्विस? सर, intergenerational connections, these are very important. So education and training, geriatric care training for healthcare professionals, and community education on aging issues, elderly education on healthy aging. So policy recommendations, increase funding. ये नहीं होगा, मुझे भी पता है अगले 20 साल तो नहीं होने का। So हमें वे आउट निकालना है, इसके बगैर डेवलप नेशनल जीरियाट्रिक केयर स्ट्रेटजी ये हो सकती है। और इम्प्लीमेंटेशन ऑफ एज फ्रेंडली पॉलिसीज, सिंपल बातें कुछ हुई भी है, उनको लाइनों में ना खड़ा होना पड़े, उनको प्रायोरिटी सीट्स मिले, प्रायोरिटी टॉयलेट्स हों, जहाँ पे वो आसानी से, और ऐसी फैसिलिटीज ऐसी पब्लिक प्लेसेस पे हों जहाँ वो आराम से बैठ सकें या सपोर्ट लेके खड़ा हो सकें। सो रिसर्च गैप्स इसमें बहुत ज्यादा है, एंड आई वुड एनकरेज, स्पेशली पीजीआर से तो मैं कह के अभी थक गया हूँ, तो इसलिए मुझे पता है उन्होंने नहीं करना, जो स्टूडेंट्स करना चाह रहे हैं दे कैन कॉन्टेक्ट, और हम इसके ऊपर कुछ प्लान करके बना लेते हैं प्रोजेक्ट, ताकि हम उसे पब्लिश कर सकें। Need for studies on elderly health outcomes and funding opportunities for research. हमें नहीं जरूरत funding की, we will do without funding इंशाल्लाह। Challenges and opportunities क्या है? Addressing geriatric care challenges, opportunities for innovation and growth, collaboration and partnerships, and in conclusion, Pakistan's elderly population needs support. Evidence-based solutions can improve care, and collective action is necessary. And before I go, I would just like to watch this video, and the message is कि आपने अपना बचपन अपने वालिदैन के साथ गुजारा है, for you people, अब क्योंकि मैं भी उसी एज में दाखिल हो रहा हूँ, तो अब मेरा बुढ़ापे का बचपन मेरे बच्चों को बर्दाश्त करना चाहिए।
पिंकी,
जी पापा।
मम्मी को दे दो
समोसे।
एक मिनट, ये दादी के लिए।
मेरी दवाई लाए?
हाँ।
कोई पिंकी, क्या है?
दवाई।
पिंकी, जब पापा से पूछ क्या वो कितना लेंगे?
पापा आपको दो दूँ?
नहीं, एक ही देना, और जरा चाय का भी देखना।
हाँ मम्मा बना रही है।
ये नथुराम का है क्या?
हाँ दादी, नथुराम के।
ये लीजिए आप। पता नहीं अब कैसे बनते हो।
वैसे ही बनते हैं माँ, जैसे पहले बनते थे।
पहले तो यूं बड़े बड़े बनते थे, असली घी में बनते थे, उसमें बादाम डाली हुई रहती थी, पता नहीं। पिंकी
जी,
एक टुकड़ा देना मुझे, थोड़ा चख लूं।
कुछ नहीं मिलेगा आपको।
एक टुकड़े में क्या हो जाएगा?
क्या हो जाएगा? क्या मतलब क्या हो जाएगा? उल्टा सुल्टा खाते रहती हो, तबीयत खराब करते रहती हो, हमें और कोई काम नहीं है? कभी चिक्की छुपा के खाती हो, तो कभी भुजिया, चाहे लूज मोशन की नदियां बहती रहे।
100 बार सुना चुका है।
अब बच्ची हो, कुछ समझ नहीं पाती हो?
तू अकेला ही समझदार है, मुझे कुछ आता ही नाही, जैसे काही अकेला समजदार आहे. कुठे जायचं, काय करायचं, काही कळत नाही. एकटा जीव म्हणतात सदाशिव, काय करायचं. जायला पण कुठे जागा नाही. मुलं सगळे मागे लागतात, हे नको खाऊ, ते नको खाऊ. कुठे जायचं, कुठे उठायचं, कुठे राहायचं.
Thank you very much.
Can be the most difficult, but for me today is the easiest. But there's some difficulty which I'm facing. डिफिकल्टी तो नहीं, एक अजीब सी मैं नोशन में पड़ गई हूँ। सबसे पहले प्रोफेसर अली मदी हाशमी ने अपना पर्सपेक्टिव बताया that when he was 20, 30 was elderly, 30 पे 40, 40 पे 50. I'll tell you the female perspective. कल मैं बाजार गई ये शॉल लेने, तो वही बाजार, वही लिबर्टी के गलियां. So when I was in FSC, अभी इतनी हाइट में नहीं हुई थी, तो the same people would call you अच्छा बेटा या चलो कोई बहुत करना है तो बहन, तो बेटे से बहन पे आया, बहन से बाजी पे आया, छोटी बाजी पे आया, फिर बड़ी बाजी पे आया. लेकिन कल तो इंतहा हो गई सर. माजी पर्सपेक्टिव जब आप बात कर रहे थे. अच्छा फिर दूसरा क्या हुआ? मैं इधर आई बैठी, एक साइड पे प्रोफेसर इमरान हसन, दूसरी साइड पे प्रोफेसर अली मदी हाशमी, फिर प्रोफेसर शहजाद आ गए. इन्होंने मुझे दरमियान में बिठा लिया और जब मुझसे बात करते हैं तो बिल्किस भूल जाते हैं, इनको आयशा याद आती है. अब आयशा कौन है? आयशा मुझसे 6 साल, मैं ख्याल में हाँ 5.5-6 साल बड़ी बहन है, जो कि इन लोगों की क्लास में. तो मैं इनके सामने बिल्किस कभी भी नहीं हुई. अंदर से निकलते ही मुंह से भी निकला आयशा, अच्छा नहीं हाँ बिल्किस. तो अब मजीद एक और मसले में पड़ गए और फिर ऊपर से आ गई वर्दा. माशाल्लाह आई एम सो प्राउड ऑफ यू वर्दा. अब वर्दा जब मैं इधर पढ़ाती थी, सो आई लेफ्ट, एक्चुअली आई एम फ्रॉम फातिमा जिन्ना मेडिकल यूनिवर्सिटी, मैं ग्रेजुएट हूँ एक्चुअली, लेकिन आई स्पेंड मोर ऑफ माय करियर एट किंग एडवर्ड मेडिकल यूनिवर्सिटी. अब ये लोग याद नहीं करते, थैंक यू वेरी मच. डॉक्टर अली मदी हाशमी ने याद किया, वर्दा ने याद किया, सुमैया ने याद किया, लेकिन मुझे खुद में नहीं याद आता. उसकी वजह ये है कि आई लेफ्ट इन 2022. तब आप फाइनल ईयर हो, 4th ईयर, सो अभी आप पैदा ही हुए होंगे, सो यू मस्ट बी इन फर्स्ट ईयर देन. सो शायद आप लोगों की वो व्हाइट कोट सेरेमनी मैंने करवाई हो. तो वर्दा used to be वर्दा आप कब की ग्रेजुएट है? So she used to be a little 3rd year, 4th year and final year हमारे सामने. छोटी सी बच्ची थी, चुलबुली सी, and now I have seen her grow into such a mature and an able clinician and I'm so proud of you. और फिर आगे डॉक्टर नासिर बैठे हुए हैं. ये वो टीम है when I moved from FJ in 2004, तो इस टीम के साथ मैंने काम किया था. डॉक्टर नासिर, डॉक्टर आबिया, प्रोफेसर ज़फ़रुल्लाह खान. So this lecture hall brings so many memories. और ये तस्वीर नजर आ रही है आपको? बस ऐसे ही होता है. ये कौन सा हैंड है? ये है तो वैसे दोनों लेफ्ट, लेकिन इस हाथ में चेंज होने में कोई खास फर्क नहीं. So it just the time goes like that. और वो बिल्कुल आपका जो पर्सपेक्टिव है, time passes like that. My job has been made very easy by Dr. Abdullah and by Professor Ali Madi Hashmi. This was actually what I was to talk about. और जो आखिरी वीडियो थी ना, वैसे सर वो जो आखिरी वीडियो नराथम, वो जो नथुराम समोसों वाली जो है, वो अभी हमारे साथ होना शुरू हो गया. अम्मी आप तो नहीं खाए, मतलब आप है ना बेजरूरी नहीं, आप हमें दे दें. उस दिन लिंक के चॉकलेट की इतनी बड़ी बार आई. डॉक्टर अथर सईद ने, माय हस्बैंड इस क्लास पर उनको भेजी, तो मेरे दोनों बच्चे कहते आप दोनों तो नहीं खाएंगे, हमें दे दें. तो ये जो दिस वीडियो वाज सो इम्पैक्टफुल. ये बात सूरह यासीन में अल्लाह ताला ने हमें बताई है. कैन समवन रीड दिस आउट फॉर मी? और इंग्लिश में बेशक बोल दें. Any one of you जिसको नजर आ रहा है, हमें नजर भी नहीं आता, believe you me. हाँ जी. And he to whom we grant long life, we reverse in creation. So वो आपने बहुत दफा नेट पे वो मुझे बड़ा रिस्पेक्टफुल लगा कि मैं इस आयत के साथ वो बनाऊं, लेकिन एक है कि बेबी से खड़ा होता है बच्चा खड़ा होने के चलना शुरू होता है, फिर वो होता है और फिर क्या होता है उसको, फिर वो डाउनवर्ड्स जाना शुरू हो जाता है। लेकिन जब वो डाउनवर्ड्स जाता है ना तो वाकई वो बच्चा बन जाता है। ये सूरह यासीन की जो बात है ना, ये हम सूरह यासीन हम सारे बहुत पढ़ते हैं ना, मतलब कई दफा पढ़ी है, कई दफा तर्जुमे के साथ, लेकिन when you live through it and when you observe, especially your patients, your people close to you, आप में से how many of you have actually dealt, मैं patient और वो encounter की नहीं बात करी, have actually dealt with an elderly patient in the family or near ones, dear ones, okay. So almost I think 90%. अच्छा, how many of you have dealt with babies या छोटे-छोटे बच्चे in the family? अच्छा, वही हाथ दोबारा खड़े हुए हैं. Could you balance out the similarities? Many.
Babies cannot speak and elderly can communicate.
Sometimes not. Believe you me, sometimes not. So those who are close to me, they know of a person who's very close to me and I'm dealing with him day and night. And last night, मुझे सुमैया कहे मैडम लेक्चर भेज भी गए. अब वो लेक्चर मैंने रात को एनुअल डिनर के बाद तैयार करना था. अब वो तैयार ही नहीं हो सक रहा था because the mere fact that that specific individual had many visitors yesterday. So many of the alumni are his old friends. तो वो आ रहे थे, so simply that thing disturbed him. तो आपने कहा ना communicate कर सकते हैं. I am very close to him. He is my husband. So I know कि उनके mind में क्या चल रहा है. तो he was not able to communicate कि मतलब he was overwhelmed आप कह सकते हैं. But the only thing in which he communicated was lack of sleep. ठीक है ना, अब वो मैं symptoms आपको सारे बताती हूँ. Signs: lack of sleep, confusion, did not want to have dinner, wanted to have water again and again. So अभी वो सारी चीजें हैं जिसका अभी अब्दुल्ला गुजर साहब ने, and you know what I simply did? I just sat beside him, sir. मैं यूं बैठी जैसे आप बैठे थे, and I just held his hand. अब मैं अब रात को एक तो मेरा अपना फ्यूज उड़ा हुआ था, मुझे सुमैया का बहुत प्रेशर था, उसमें मैं डरती बहुत हूँ और था डरना चाहिए, तो I just held his hand and he went to sleep. So ये भी है, they are not able to communicate as fully as they could, as they used to. Could mean as they used to. So this is what we were to talk about. Again, I'll keep my talk very busy. I'm sure I am the person in between you and the tea, right? So this is going to be tea after this. Yes? Huh. So I'll be very brief. क्योंकि ये बहुत चीजें आपके very wonderfully described since morning. My specific, the area which I would stress upon is the acute illness in the elderly and their atypical manifestations. So please remember that in the elderly, simple things may present atypically. Now see क्या क्या वजूहात हो सकती हैं, जैसे यहाँ लिखा है, and this has been discussed in almost all the presentations since morning. They have reduced physiological reserve, they have altered immune response, multiple conditions, multiple comorbidities by this age, polypharmacy. Sometimes they forget what they have taken. Anti-Parkinsonism drug. I remember a patient who took 2 tablets of Sinomate instead of 1, and was brought to the clinic in a state of confusion, and they could not figure out. फिर जो सबसे छोटी पोती है ना, उसने कहा कि मुझे लगता है इस पत्ते में से, मैं यहाँ बैठ के अपना टैप पे खेल रही थी, मुझे लगता है उन्होंने 2 दफा लिया. मैंने उनसे पूछा भी, and she said नहीं मैंने नहीं लिया. तो मामा मुझे लगता है कि उन्होंने 2 दफा ली, and perhaps that was the only reason. सारा हमने CT कराया, सब कुछ कराया, nothing. So as time passed, metabolize हुई and she improved. So and cognitive impairment. ठीक है ना? So ये सारी चीजों की बात हो रही है. ये एक बड़ी interesting concept है, eyes और geriatric medicine. चाहे वो we talk about the acute disorders or the chronic disorders. So eyes क्या क्या है? आई कोई बोलेगा? सबसे पहला क्या है? ठीक है. अच्छा ये कहना बहुत आसान है. मेरा जो any one of you is from is in the FCPS course? ठीक है. So अब आप you are writing research papers. So we used to write dissertations. The topic of my dissertation back in the year 2003 was the pattern of diseases in geriatric patients admitted at Sir Gangaram Hospital. 2003, and I actually published it in, I think, Annals of King Edward Medical College at that time in the year 2004. You can check it out from that. The reason was it intrigued me even then, that why, what Professor Imran Hassan has said, why no subspecialty of geriatric medicine in Pakistan? ये मुझे उस वक्त भी होता था. You are all in the wards. When you enter, how much percentage would you say is occupied by the elderly? Beds में 70, 80. हमेशा ER में हर वो almost मतलब majority of patients, चाहे वो West Medical Ward है, चाहे वो East Medical Ward है, चाहे Medical Unit 1 है गंगाराम का, चाहे सियालकोट है, चाहे गुजरांवाला है. मैंने जहाँ काम किया है, साहिवाल में सर ने काम किया है, जहाँ मैंने काम किया, see majority of patients presenting और जो elderly हैं. So why not have pediatrics अगर है, so why not geriatrics? Immobility, instability, incontinence, intellectual impairment, iatrogenic complications, impecunity. You know what impecunity means?
Having no money.
No money, financial restraints. ये सारे eyes हैं, and believe you me, इनकी एक के ऊपर we can talk, we can hold a seminar शायद पूरा ना हो. But believe you me, ये है problem. The other day, I think 4 days back, an elderly was brought in a state of delirium. Confusion नहीं था, delirium था. And you know what the reason was? Fecal impaction. कुछ समझ ना आए, CBCs was right, metabolic profile was right, chest X-ray सब कुछ, MRI कुछ समझ नहीं, MRI भी करा लिया. So वैसे ग्राउंड में मुझे ख्याल है, मैंने कहा when did she pass through? Not since she is here. When we call the relatives, हमें नहीं पता जी, वो तो अब आपको पता है ना, हम तो दोनों काम करने वाले हैं. मतलब यानी कि they were out during the day for the jobs. जब हमने PR किया, impacted hard fecal matter, जिसके बहुत मुश्किल से वो evacuate हुआ, and the lady was fine in 6 hours. So ये please इसकी पीछे picture ले लो, net पे search कर लो, this is worth it. लेकिन एक काम करना, whenever you come across an elderly patient, please screen these out. अगर आज के लेक्चर में आप बाकी कुछ भी ना सुने, हालांकि take home message कुछ और है मेरा, लेकिन if you take this message, screen the elderly for these eyes. ठीक, कहीं गिरा तो नहीं, कहीं incoordination की वजह से hesitant to move तो नहीं, hesitant to move से ना होने की वो फिर what would result will be what Professor Ali Madi Hashmi was talking about, mental stress and सब कुछ. These are some case scenarios और ये genuine case scenarios. इनको मैंने बहुत लंबा नहीं किया because of restraint of time, लेकिन genuine है, and the senior lot amongst us, even those who are doing their trainees etc., training etc., would relate to these scenarios. So confusion हुई, था वो afebrile, निकला क्या? Pneumonia. Atypical manifestation बेटा. कोई चेस्ट पेन नहीं थी लेकिन था MI, ब्रेथलेसनेस हुई लेकिन टिपिकल चेस्ट पेन नहीं हो रही थी, so ऑटोनॉमी न्यूरोपैथी हो चुकी होगी अब तक, कुछ समझ नहीं आ रही, बार बार गिर रहा है, UTI। ये जेन्युइन केस सिनेरियो है, ये आई डिड नॉट पुट देम अप, ये पूरे लिखे हुए थे इन अनदर टॉक आई हैड गिवन, लेकिन मैंने कहा टाइम थोड़ा सा कम है। अच्छा, सिंपल डिलीरियम कंफ्यूजनल स्टेट है, तो अगेन UTI। अब एक कोई नई दवाई ले ली है तो जी पता चला कि ड्रग इंड्यूस्ड इस तरह है जैसे मैंने अभी आपको बताया, दे हैड गॉन इनटू पॉलीफार्मेसी, क्योंकि दी तो आपने एक ड्रग, लेकिन उसने कहा कि मुझे दर्द के लिए, सो कंफ्यूजनल स्टेट में इस तरह आया कि आपने उसको एंटीबायोटिक दी, लेकिन चूंकि उसको जिस्म में दर्द थी उसने कोई एक और चीज ले ली, उसने न्यूब्रोलफोर्ड भी ले ली, न्यूब्रोलफोर्ड में ऑर्फेनेडिन सिट्रेट है, ऑर्फेनेडिन सिट्रेट जो है वो ड्राउजीनेस करता है, देन उसके बाद इन एडिशन टू दैट ही वाज ऑलरेडी ऑन एन एंटी डिप्रेसेंट, तो सीटान्यू एसिटालोप्रान ले रहा था, जो जी एसिटालोप्रान ने मजीद उसको ड्राउजी कर दिया, एंड द रिजल्ट वाज कंफ्यूजन, ड्राउजी, एंड द रीजन वाज पॉलीफार्मेसी or even side effects of a new drug in presence of reduced pharmacokinetics and already existing long list of prescription drugs. Okay, so please, eyes याद रखो, जो इन्होंने वंडरफुली बताया, I would not go into the detail, ये अगली 2-3 स्लाइड्स पे थे, I'll just skip through them. Complete examination, बैठ जाओ, हाथ लगाओ, many a times आपको हाथ लगाते ही पता चल जाएगा कि what the problem is, or patient sometimes might not be complaining, just like the babies do. Babies का भी ऐसे ही ना, so those who have been to pediatrics, and obviously it has to be multidisciplinary approach. So this has been very well discussed. Way forward जो थी, जो इस सड़क पे आपने चढ़ना है ना, ठीक है, हम तो लगे ही हुए हैं, आई एम टेलिंग यू, दिस वाज माय फर्स्ट एवर स्टडी, और जो डिसर्टेशन आप करते हैं ना, अनफॉर्चुनेटली बिकॉज दे आर स्टूडेंट्स आर वेरी रिसर्च लिटरेट, लेकिन हम लोगों की तो वो कम्युनिटी में एक सवाल पूछना होता था, उसके रट्टे मारे थे मैंने, तो सच्ची बात है। एक्चुअल रिसर्च तो फिर आपने बाद में की जब सर पे पड़ गई प्रमोशंस के लिए, और उसके बाद फिर ये कि जब हमने देखा कि इट इज द नीड ऑफ द डे, बट एट दैट टाइम दैट वाज द फर्स्ट जेन्युइन दिल से की हुई रिसर्च व्हेन आई डिड इट फॉर माय पोस्ट ग्रेजुएशन, एंड दैट वाज ऑन जेरियाट्रिक्स। लेकिन उसके बाद आई एम वेरी सॉरी टू से कि लास्ट almost 25 years not much has been done on it, so we are on this path, but it's you actually who are going to, you know, take the baton from us. Baton का पता है ना, वो जो रेलवे रेस में नहीं लेते, so you are the ones who are going to take the baton. वैसे हम ज़्यादा ही बूढ़ा कर दिए रिटायरमेंट में कुछ साल है अगर जिंदगी रही, लेकिन दिस इज वेरी इंपॉर्टेंट, जो प्रोफेसर इमरान हसन ने वंडरफुली डिस्क्राइब किया, इट वाज एक्चुअली द सेम थिंग्स व्हिच आई वाज गोइंग टू टॉक अबाउट। देयर हैज टू बी some straight pathway for a geriatric patient, either presenting in the ER, in the out clinics, or admitted in the ward, or presenting elsewhere in the family medicine clinics. There has to be some formal training and some clear path as how they would be entertained, just like we have for the pediatrics. So ये वही बातें हैं, टेली हेल्थ की बात हो रही है and सब कुछ. So these are my take home messages कि please remember वो eyes please याद रखना, मैं इधर नहीं लिखे लेकिन that is my take home message. Atypical presentation of common disorders. Common होते हैं, UTI कितनी common है, pneumonia कितना common है, MI is very common लेकिन atypical manifestations. And please अगर मैं या कोई यंगर बंदा गिर जाए, शायद वो भी इमरजेंसी हो, but an elderly falls, even if they do not sustain a fracture, सबसे पहले ये देखते खड़े हो जाओ, खड़े होके देखो, खड़े हो, ये खड़ा हो गया, इसको फ्रैक्चर नहीं। No, it is a manifestation and unfortunately maybe a manifestation of something sinister building underlying. अच्छा, ये है ना, वाइटल्स ठीक है मैम, वो क्या होता है जो हमारा होता है डेली मॉनिटरिंग चार्ट, TPN, तो ठीक है मैडम, वाइटल्स ठीक है, वाइटल्स आर ठीक, बट प्लीज इस ये जो निशान है ना, ये निशान ठीक है, वाइटल ठीक है, डजंट मीन कि पेशेंट may but may not be stable. So please remember, vitals are not the only thing. CGA, comprehensive geriatric assessment, है वो उन्हीं लाइंस पे जो आप थर्ड ईयर से सीख रहे हैं. But do that. Do not take a patient looking visibly fine to be stable. This lecture is dedicated to my father. He retired from here as a professor of surgery. So can you recognize this place? ये entrance है, और साथ जो बैठे हैं जो हमारे सीनियर हजरात हैं, तो ये अवान साहब हैं, और अवान साहब this was in the year 2010. उस वक्त उनके रिटायर हुए 14 साल हो गए होंगे, हाँ. And he came here on a sports day. So अगर देखें आप, इन्होंने joggers पहने हुए, ठीक है. This is my younger one and this is my elder one. जो younger one है गोंगलू, ये माशाल्लाह A2 के एग्जाम्स दे रहा है माशाल्लाह, and this one is in lungs. तो ये है, और ये भी शायद अभी भी हैं, रिटायर हो चुके हैं. ओके, सो सरफराज साहब हैं, सो ये भी इधर ही होते हैं. और ये आपने इधर देखे द प्राइड वाज कि वहाँ आयशा का नाम लिखा है और वहाँ आमिर का नाम लिखा है. So he was so proud of his children. इसका दिखाने का पर्पस ये था कि हम सारों की ऐसी स्टोरीज हैं. प्रोफेसर अली मदी हाशमी ने वो स्टोरी शेयर की, डॉक्टर इमरान हसन ने वो स्टोरी शेयर की, और इवेंचुअली हमने भी, डॉक्टर इमरान हसन ने, मेरे ख्याल में आपने ही कहा कि इन्होंने कहा ये सफर इधर से इधर होता है, तो मैं उसको दिल में सोची थी, फिर उसके बाद इधर हो जाता है, ठीक है ना. ये सफर तो चलता है, लेकिन द थिंग इज कि ये याद रखना कि जो इधर बैठे हैं, दे आर गोइंग टू ब्रिंग योर लेगेसी फॉरवर्ड, ठीक है. सो वो लेगेसी घर की लेगेसी भी हो सकती है, वो लेगेसी ये लेगेसी भी हो सकती है जो आप इन 2 दिनों में 3 दिनों में ऑफ योर कॉन्फ्रेंस, जो द एजुकेशनल part being the education and the academic things being imparted to you, तो यही legacy आपने आगे लेके जाना है. So I think if I conclude my lecture, 1, the 5 I's, and number 2, कि अब आपने geriatrics चलानी है. हम अभी भी हैं, अभी तो खड़े ही हैं, अल्लाह ताला खड़ा रखे, लेकिन इधर आपके सीनियर्स हैं, डॉक्टर अपने नासिर, डॉक्टर हसन, बस तो हो जाता है ना सर, डॉक्टर वर्दा, प्रोफेसर अली मदी हाशमी, प्रोफेसर इमरान हसन साहब, all of them are here, डॉक्टर आयशा is here. So अब सारों के साथ you are going to, जैसे मैंने पहले कहा, take this baton forward. Thank you so much.
इसके बाद हमने सर्टिफिकेट डिस्ट्रीब्यूशन करनी है, तो I'll just briefly go through each of these lectures. Dr. Aisha, she presented diabetes management elderly. बड़ा अच्छा फॉर्मूला मैडम ने बताया कि अगर हम सिर्फ डेकेड को कंसीडर कर लें तो वही हमारा एचबी बन जाता है. थैंक यू मैडम. डॉक्टर बिलाल का तो हर बंदे ने आया कि सबका काम डॉक्टर बिलाल ने आसान किया, सर डॉक्टर बिलाल ने आसान किया, तो फिर आप टॉक करना सब पे था, सब ने आपकी टॉक से फायदा उठाया. थैंक यू वेरी मच. टैक्सोनॉमी पढ़ते थे, सर ने एक साहिब लोग को इंट्रोड्यूस कराया, 5 वेज ऑफ दैट. डॉक्टर रतन नहीं है, फूड ट्रीटमेंट हमने उनसे सीखी, और इंटरेस्टिंगली जो स्टडीज उन्होंने दिखाई वो तो बहुत वैल्यूएबल हैं. तो होपफुली हम भी स्टार्ट करेंगे, हम प्रोबायोटिक्स पे ज्यादा फोकस करेंगे. डॉक्टर अली मदी हाशमी कैडेट एंड हाई, और सर ने बड़ा अच्छा बताया, एंड सिर्फ समटाइम्स ओनली ट्रीटमेंट इज कम्युनिकेशन, बस कुछ नहीं करना. डॉक्टर इमरान सर सर से हम हमेशा ही सीखते रहते हैं। सर ने बड़ा जबरदस्त सजेशन दिया कि हमें हमारी वार्ड में, बल्कि सबको मेडिकल वार्ड्स में जेनेटिक बेड्स डेडिकेट करने पड़ेंगे, तभी ये स्पेशलिटी आगे चलेगी और हम ही से लेके चलेंगे इंशाल्लाह। सर विल फॉरवर्ड सर। और मैडम ऑलवेज एंड नोट मेरे पे 5 eyes। थैंक यू मैडम, थैंक यू वेरी मच फॉर कमिंग हियर वंस अगेन। हमने हमेशा मैडम से सीखा है, शुरू से सीखते आए हैं। So, in the end, I'm extremely thankful to all our distinguished speakers for their invaluable expertise. I'm thankful to Dr. Varda, who was skillful moderator. I'm also thankful to Dr. Sumaya, he is the focal person. And I am also thankful to all our attentive attendants. Thank you.
Now the certificate distribution, Dr. Nasir will be handing over all the certificates to our speakers. So first of all, Dr. Aisha Sa. Okay. Now I would like to invite Dr. Abdullah Gujar, Dr. Aisha Sakib, and Professor Dr. Alimadi Hashmi, and Professor Shadab. And Professor Dr. Bilkis Shafi. Ma'am, you are the person, मैंने 3rd year, 4th year, final year में मैडम से पढ़ा है, and she is the reason कि मुझे मेडिसिन में जो है ना डिस्टिंक्शन मिली है इनकी वजह से। बच्चे से क्या कुछ पूछेंगे, बस कर दे मुझे डिस्टिंक्शन दिलवा दी। Okay, so now Professor Dr. Imran Hassan, we are not having a seat. Okay. Now we can welcome Professor Dr. Alimadi Hashmi and Professor Imran Hassan Sahab along with Dr. Nasir to hand over the certificates to you. Oh. Okay, now first of all, we will be giving the certificate of appreciation and participation to the Dr. Aisha Sakib. Just give this presentation to you people. Now the most favorite session, जो कि सबकी जो है वो जान रहा है, Dr. Abdullah Gujar. Dr. Athar Said is the I think he has left. So now the Professor Dr. Alimadi Hashmi. Then Professor Dr. Imran Hassan Khan. This video has made me very emotional. And in the last but not the least, always the most favorite personality, Professor Dr. Bilkis Shafi. Please welcome. Oh yes, please. Dr. Tabinda. Okay, now you people and we all, you know, Dr. Sumaya, focal person. Okay, I'm highly thankful to you people, nurses, 4th year MBBS, and especially the West Medical Board. You people have truly participated in this session, and also the psychiatry department. Now we all are moving towards the Maqbool Ahmed Group. No one is leaving. We all are going for the last session here. Okay, please.